Okay, we're live.
Very good. Well, good morning, everyone, and welcome to our April meeting of the Texas Child Mental Health Care Consortium. I know you guys are extremely busy in the midst of the legislative session and everything else that's going on. So again, thank you for your time and energy and engagement over the next several hours as we try to improve the services that we are providing through the funds from the legislature to improve child's mental health here in Texas. So with that, why don't we do the official roll call? And Luann, I'm going to have you do the roll call for us.
Okay. Dr. Lakey?
I'm here.
Dr. Goodman?
I'm here too.
Dr. Williams?
Hello.
Dr. Liberzon?
Here.
Dr. Harper?
Here.
Dr. Trevino?
Here.
Dr. Thompson?
Hello.
Dr. Martin?
Here.
Dr. Podewells?
Here.
Dr. Chasse?
Present.
Dr. Nemiroff?
Here.
Dr. Strakowski? Dr. Ton? Dr. Robert? Dr. Wagner?
Here.
Dr. Vo?
Here.
Dr. Suarez?
Here.
Okay. Dr. Newland?
Here.
Dr. Pliska?
Here.
Dr. Escamilla? Riarca?
Here.
Dr. Bryant?
Here.
Ms. Nichols?
Here.
Dr. Taminga?
I'm here.
Dr. Ibrahim?
Here.
Mike Maples? I know Sonia Gaines is going to be late. Dr. Silverman? Dr. Martinez? Dr. Keller?
I'm here.
Ms. Castle?
Here.
Ms. Wesley?
Present.
And I know that Dr. Borges is going to be late, so I believe that's it.
Very good. And the total number?
Oh, wow. Okay, I wasn't counting.
24. So we're well over our 18 that we need for a quorum. So we are official and we'll move forward. So again, good to see everybody and welcome to the Texas Child Mental Health Care Consortium. We have a pretty full schedule today, and so I'm going to make sure that we move forward and all the agenda items at a good pace. But it really is good to see everybody. A little bit about thinking through the timing for the next meeting. The legislature is in session right now. In May, there'll probably be still some things that they are finalizing, and I think it would be probably best for us to wait until May or June to have our next meeting. And so we'll probably take a time off from the full consortium meeting in May, so that in June we can let you know how everything landed and how we plan for the next year. Does that make sense? Any thoughts related to that before we move forward?
Yeah, this is fine with me, David. You won't wait until you won't wait more than 5 minutes before you let us know how things happened, will you?
I will let you know as soon as I know related to the funding item. There's a lot of other bills and a lot of other issues that need to be resolved, and it's I think probably best to I'll let you know about those big issues, but to give you a complete picture, I think it's probably best for us to wait until early June to provide that picture. Okay. All right.
Did we, Dr. Lakey, did we settle on a date in June, or is that still?
I will have to ask my folks related to the date in June. Luann or Nagla, do you guys know when the date
is already set? I can look it up really quickly and I'll put it in the chat. Oh, I'll say it.
Okay, great. I recall, I believe that was falling in a time when I will be out of state.
Okay.
And so I was hoping it might have gotten changed, but whatever. We'll figure that out. Okay.
All right. Very good. Well, why don't we, the first order of business we have is to approve the minutes for the last meeting.
Sorry, Dr. Leahy, to disrupt. It's June 18th is the date.
Okay, so the first order of business we have is to approve the minutes from our previous meeting on March 8th. If people could just take a quick look at those minutes and see if there's anything that they believe is an error or needs to be edited, please let us know. I'll give you a minute to take a look at that.
I move to approve.
I have a motion to approve from Dr. Vo.
Second.
Second from Dr. Wagner. Any further discussion? Hearing none, all in favor of approval of the minutes signify by saying aye.
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 Any opposed? Same sign. Anybody abstain? Hearing none, the minutes are approved by unanimous vote. All right, let's go to item 3 and several things that we wanted to touch on today. Starting off with the legislative session, and I'm going to do a quick handoff here to Sean Griffin, who's our Associate Vice Chancellor for Government Relations here, that does a lot of our health GR work, or is the key person to our health GR work. And Sean, let me turn the virtual podium over to you to give an update related to the variety of mental health things that are going on during the legislative session, especially the budget and where things are related to yesterday's conversation on the House floor and how things are going into conference committee. Sean?
Sure. Okay. Thanks, Dr. Leahy. Good morning, everyone. So we're coming in on the last 5 weeks of session, which is going to be a very, very busy time. A lot of things are kind of coming into focus. We have some more clarity on what's going to move and where these decisions are heading towards. As Dr. Leahy just referenced, yesterday was the big House budget day. And so that was where they passed their version of the state budget out on the House floor. Pretty drama-free for the most part. For y'all's most important consideration, funding for the consortium, we're still at about the same situation we were at with the introduced budgets, in that the Senate has funded, the extra $19 million required to get you all to the current operational level. The House has not included that funding. They did update their rider, which gives you sort of guidelines on how you spend that funding, to align exactly with the Senate version. So the only missing piece there for them to agree on is the funding amount. I'm fairly confident, for a couple of reasons, that the Senate's version will prevail, or at least something close to that number, and we won't have to reduce any service levels at the consortium. That's because the head budget negotiator in the Senate is of course Senator Nelson, and this is her whole creation right here. So I think she's going to do everything she can to get it funded. I also think, and some of this stuff is sort of playing out behind the scenes, and it'd be a fool's game to make any guarantees on it, but the legislature and the state in general are kind of coming to the realization that in order to fully utilize the federal funds in the last tranche of relief package that was passed, we have to maintain a level of funding for our public ed and our higher ed that is the same proportion as to what it has been the last several years. And the effect of that is basically we need to add maybe up to $1 billion of funding into our higher ed side. So with y'all's funding coming through the coordinating board and going out to your institutions, if that can be counted as part of our higher education funding, then that's going to help them get to the number they need to get to maintain that maintenance of effort and pull down the funds. So I'm cautiously optimistic they'll get to that number in the Senate, but won't really know until the last couple weeks of session. After the House has now passed out their version, basically from a procedural standpoint, The Senate will receive it on Monday. There'll have to be a motion to basically reject the changes and appoint a conference committee. The Senate will appoint 5 members. Then it'll go back to the House. The House will say, okay, and appoint their 5 members. And then those 10 members will be meeting, behind the scenes from here into the rest of session to negotiate a, compromise on that. And I think there will be funding available for this and some other initiatives too. I would expect the comptroller to revise his budget estimate, which is basically the benchmark that they use to know how much money they're going to have in the next 2 years and what they can write in the budget. I think we'll be getting an update in the next couple of weeks. So fingers crossed on that. Should be, move in a positive direction and relieve some of the pressure from the legislature. So that is where we're at with the budget generally and with the funding for the consortium specifically. Another relevant budget item I think that a lot of you all are looking at is the state hospital redesign and reconstruction funding. So good news on that front. The House also yesterday passed out what's called the Supplemental Appropriations Bill, which usually is backfilling any kind of holes that we have from the current budget that ends in September. And then they also kind of take care of some other outstanding issues. Sometimes there's disaster funding and other stuff they have to hit. They did include in the House version that just passed over the Senate the full amount of funding to finish off ASH and SASH, and also funding for pre-planning for a Dallas hospital, a Panhandle hospital, and redesign efforts in Wichita Falls and Terrell. So that is good. That's all moving in the right direction. They use rainy day funds for that, which is a perfect use for that kind of one-time expenditure. So I don't expect a drastic change when the Senate reviews that, but we'll be following it to see. But good news on that front. They're making progress in it on that huge comprehensive plan. Moving on just to legislation, we're getting to the point in session where if you haven't had a hearing, the bill's probably not going to make it across the finish line. The House has some deadlines on when they can hear House bills on the floor and move them over to the Senate. And of course, those of y'all that follow this or remember your Schoolhouse Rocks know that bill has to pass both chambers in order to go to the governor. So all the bills that are moving right now have a viable shot, and the House and the Senate are already hearing each other's bills. That being, House bills are being heard in the Senate and vice versa. Those are on good track. But if you haven't gotten a hearing at all, next week is definitely, you're getting to your last breath in order to get out. If you've already had a hearing and they're working on some things, maybe the week after, if it has wheels, it can go quickly. But we're getting down the wire. I'm getting to the benefit of having to check a lot of things off of these lists, which is always a good feeling, as long as they're not the ones you want to pass. HB4 is the big telemedicine bill, and it's essentially going to make permanent a lot of the exceptions that the governor put in for Medicaid reimbursing how telemedical services. That includes, of course, the behavioral health services. So that's a good bill, and that is already over in the Senate. We'll probably get a hearing, in the next week or two. All indications point to that passing. So we will have all of the temporary measures during the pandemic, as far as Medicaid goes, should be codified from here on out, which is good. There's sort of an analogous bill on the private insurance side, actually 2 different bills that do about the same thing. They would add behavioral health professionals to the existing code that requires our regulated private insurance plans to recognize and cover telemedical services. It would also task HHSC with developing rules for where it's appropriate for audio only, which obviously is a big benefit and good tool when it comes to some behavioral mental health treatment. The bills are kind of hung up in committee, though. I don't think they're maybe not going to get out because of the health plan's opposition. They have no opposition to, and in fact, supportive and encourage the inclusion of mental health professional services. And they may just do that on their own anyway. They already are now. They take exception to another part of the bill that says you have to reimburse it at the exact same cost as in person. So they don't want to have their hands tied to that. They want it to be a case by case and negotiate with their providers. I'm a little doubtful those bills will move because of that opposition, but I do think already just what we've seen in the last year and the way things are moving, I think there'll be coverage for telemedical services. It's just the reimbursement issue they want kept off the statute. Maybe a couple others. There really honestly hasn't been a lot of movement on policy. A lot of stuff is just kind of stuck in committee, didn't get a hearing. Attention's been elsewhere, frankly, on these other issues. There is one interesting bill, though, that I would bring to y'all's sort of awareness, and that is Senate Bill, what's the number here, 640 by Senator Menendez. And it is maybe hung up because it was supposed to be heard on the Senate floor and they've pulled it down and not put it back on a calendar. So I don't know if it has issues, but it would require HHSC to do a interoperability and technology study for our behavioral health system, both, Medicaid coverage and big physician groups and others. It's trying to get at electronic health records and the way that the entire mental health infrastructure, talks with each other and follows a patient when they show up in different settings. So interesting bill, but I'm not really sure why it was pulled down. Sometimes that's just calendar maintenance. There's not enough room, but sometimes that means there's a problem and it's not moving. We'll keep an eye on that one. And we'll let you all know if there's a good role for us to play as HHSC starts to, if they do our task with that study. Other than that, don't think I have much else to really draw your attention, but if there's something that you all are following and have questions about, happy to take any questions on that or anything else that we've just gone over.
Really good summary. Why don't we start off with Dr. Splitska and then Dr. Martin? Dr. Splitska?
I just a clarification on the difference between the House and Senate. So is it that the Senate bill has what we're spending this year, or they've added something versus the House is current version is somewhat less than we have this year?
Yeah, Yashan, you want me to take that question?
I mean, I think I can, but maybe you can correct me if I'm wrong. The House kept the exact same amount of funding that we were provided. But what the Senate does is it increases the funding to match basically the ramped up level of current operating costs as the consortium has built up and gotten underway.
So the House keeps us whole, the Senate gives us a little more. Is that
not exactly? It's a little tricky. So the House, we would have to pare back down on the House's level.
All right.
Because as you all have ramped up, the continuing expenses you will need to maintain current levels of operations, we need a little more funding. Right. And that more funding is included in the Senate's version, but not the House's version.
Mm-hmm.
So on that front, is it fair to say that of the total amount of funding for the current biennium that we're in right now, the House held to that current amount? The way it was expended was less in the first year of the biennium, more in the second year of the biennium. And so the difference that the Senate put in is to maintain it at that second year of the biennium spending level.
That is correct.
Ooh,
yeah.
Right.
So we had more expenditures in year 2 than year 1. Building the budget on the Senate side keeps us at that built up level for years 3 and 4. If we go to the House side, then we would have to take a step back related to still being at $99 million versus what the current service rate right now would have us at the 118 for the biennium. Okay. Dr. Martin?
So the way the ones having to do with telemedicine, is that going to allow us to continue to do what we've been doing in our clinics in terms of having telemedicine into someone's house and insurance is going to pay for it? That's the intent, right?
That's the intent. And on HB4, the big one, that is strictly Medicaid. On the private insurance side, that had those other bills that were trying to codify it. I don't think they're going to pass because they're also trying to codify a pay parity that I just don't think we'll get through. But for all intents and purposes, I don't envision private insurance full stop, not covering telemedicine anymore. According to their testimony, they encourage it. They're fine with it. It's worked well. They support that move. They take exception with being told exactly how much to reimburse for it.
And they don't have any statutory limitation in terms of being able to provide and pay for those services via telemed, telehealth, whatever.
Right.
Yeah.
They can do it voluntarily as they are now, and I would expect them to continue to do. It's the Medicaid that we really needed to codify to ensure it was allowed.
The danger is the insurance companies are going to argue, well, you don't have the costs of an office, and therefore we're going to cut your reimbursement, which is a bogus argument because you have to have an office to see some people. and so that's a danger, that it would become economically unviable even if they fund it. They start saying, well, we'll give you $18, you know, because you don't have an office to maintain anymore. You can do it out of your study, you know.
Right. And I think, you know, not to carry their water for them, but I think that the argument they make is we just want to be able to negotiate that, you know, case by case and not be told automatically it has to be exact same.
Dr. Liberzon?
My main question was maybe to you, David. So 18 million is, you know, it's substantial, or 20 million, 19 million, it's close to 20% of our budget. So my question would be, how does it look? Can we look at that and see where did we, because we have 4 different pots of money some of that probably increased, goes to those 18 millions, which parts increase in which direction, so we have a clear sense, rather than, or we don't have this distribution yet. So I'm trying to understand, because I understand that it maintains our current activity, but is it because we increase more in Cpan and Tchat? Is it increased because we did CPV? You know, what is it? It's definitely not the research one.
Yeah, no, we use the information that you have provided us to build the budget on what the expected expenditures would be for the next biennium. And again, that they would be more than they are right now, because you have been putting in agreements with schools, and now the schools are starting to use these services, and so there's additional providers that are needed. You know, so we calculated based on the information that you gave us what the expenditures for TChat would be, Cpan would be, CPW, and the fellowship programs. And so all that was information that you gave us. We put that together, and then we put that in as the legislative request. Now, in that is the continuation of the research initiative at the $10 million level for the biennium. But that, you know, that's how we built that budget based on the input that you gave us on where you would be come August of this year, and to have in that steady level services through the biennium. And then we will calculate what the additional needs are over the next year. And then we'll do this again and go to the legislature and say, you know, we've been good stewards of these dollars. These are the schools that we've been able to go to. Now there's these other schools that have heard that they want to be part of this, or other initiatives that other local mental health authorities that want to be part of this. And then we will build that the next budget. But it's based on the information that you guys give us and the information that we see related to additional demand.
I appreciate that. I just wondered, do we have, I mean, maybe I missed that. Was it this budget request as it is shared with the executive committee, or wasn't? Or
it was, and this conversation was almost a year ago, because we needed to put in the information, and it's probably about in August of last year, because we had to get that information from you to put in the legislative request. And so that's the challenge of the process, right? It's that it's a long process between when you give us the information, when we build the information, give it to the legislature, then when they have their debate. But that was all shared in the meetings that we had together in building those budgets.
I understand that. So just to follow up on that, and when we set up a first-time budget, we understood and we're very sensitive to legislators' particular sensitivity about separating research or keeping it within the parameters that we originally discussed and so on. We at some point thought that in the future step we might need to, as we demonstrate our good stewardship of this money and success with the recruitment into the networks and building the infrastructure, we thought that we might be able to argue that we need some additional funds. So is the timing coming close to that as we proceed? What do you see it this year, next year? How should we negotiate and argue that?
Yeah, I think that the best case that you can do is to be a good steward of the funds we've been given right now. And again, we'll talk about that later today, but these research initiatives are being developed. I think the legislature will be very interested in how it is improving care here in the state of Texas and that applicability. And then we can look at that in another session. The legislature, if they desired, they could put additional money in, but the direction that we had was build the budget based on what our expenditures are related to the current expenses, and that's the way that we've done it. Does that make sense, Israel?
It makes sense. I was just thinking how to move forward, because it's clearly as we increase our clinical activity, obviously, and that's expected and it's good. It's a natural growth out of clinical need,
I think the big win for us on the research side this time would be for the legislature to keep us whole related to the funds for the legislature, that they keep on providing. $10 million over a biennium is a significant first investment, and we need to make sure that these projects are stood up and provide the information that we need and they need to improve mental health services here in the state of Texas. And then I could see them putting in more money. I think right now they would just like to make sure that these projects are maturing and continue to move forward. Andy, I see you'd like to, you've had experience in this. Anything you'd like to say about the budget, Andy?
Yeah, I mean, I just think we need to all keep in mind that this is a very tight budget. And so, and it's less tight than we thought it was going to be. We thought it was going to be like crazy emergency tight. It's just regular, very tight. So I think the fact that there's discussions going on to continue what we're doing right now at the level we were in year 2 is an amazing accomplishment. And everyone here should feel like you are among the most successful people in the state of Texas. And the fact if that gets through, I think anything beyond that, just, it just wasn't going to happen this session. I mean, there is a separate bill going through that in the House to do some dramatic expansion of research in the area of brain health, which is on its own track and which is, being discussed and moving forward. So I think there are other, so it's an active discussion around that. But in terms of what can happen through the consortium, I really think what's in the Senate side is an amazing win if we can get it.
I agree. If we can get where we were on the Senate with not only kind of putting the current amount of money in, but more related to the expansion of these services, holding us solid related to the research dollars, and then have us demonstrate to them the stewardship and the programs are being rolled out and are providing the information. That's going to be a very strong platform. And I think Andy is exactly right. Going into this session, people were looking at dramatic cuts, and to come out with more in the midst of a session like that will be a tremendous win. And we owe a tremendous debt of gratitude for the legislature for their support of this initiative.
To me, my question is not to minimize the success and the importance of that. My question is based on observation of how our research efforts are going and the success of the both network and recruiting. I think we will be able to demonstrate that we are good stewards of this money, and we are making the plans that come to life, and there will be value to that. So I'm much more confident about that now than I was a year ago. And my point is that I'm asking early because realizing that this session is probably, we'll be happy with what we get. But if we have to start thinking how to build it in for the next session early enough, we can make a case.
No, Israel, I think that's all fair. And so my advice to the group would be that this next year will be really, really important related to those items. And just like a year ago, we had to put in our budget that we will hear about hopefully within the next month. A year from now, we're going to be on that same cycle, and we can look at all those things for the next session and make the case that these different initiatives have matured and have come to a level that would warrant that maybe additional investment. That's a conversation we're going to need in about a year from now.
Well, we'll start to prepare.
Yep. Okay. Dr. Escamilla?
Yes, thank you. So this might just be getting some clarification. And I want to commend everybody, including the legislators, on what you guys are proposing and what it looks like might come through. I think it's fantastic. The question I had was, when we put the budgets together originally, we broke them down in terms of startup cost and continuing operational costs. So when you say that the bills would continue the current budget, does that mean the total current budget or just the operating cost? And do we get to rebudget if some of them are startup?
So no, I think that's a good question. We right now meeting institution by institution, looking at their current expenditure rates, how the different programs are maturing. We will have more information. The next month we'll have more information related to what the legislature has decided, but also you have now a year's worth of additional information. And so there is a possibility of doing some of those adjustments, but it will be, the starting point would be what you provided us related to what those operating costs were going to be. I think the first 2 years, there were startup costs that had to be put in place, whether they're phone systems, data systems, a variety of other things that we won't have to do again, except for the maintenance that has to go on with those projects. But we will have, institution by institution conversations related to what you predicted, now how much funds are available, and how your budget may or may not need to be adjusted accordingly to that information that we have.
Okay, thank you.
And then we'll bring it back to the full consortium and be very transparent with those changes that have been made in order to meet the need that you have.
And I'll add real quick on that subject. Both riders for both versions, House and Senate, allow for you all to transfer between programs up to 10%. And if you need to transfer more than that, then you seek approval from the leadership of the LBB. But you've got that wiggle room in order to adjust.
Luann?
Remind everyone that on page 20 of the biennial report, you will see that 118.5 budget proposal for the biennium beginning FY22 and ending FY23. So if you have questions about that particular amount and where it came from, it was also discussed at the executive committee meeting prior to submission of the biennial report. So you can look there.
So another thing that I think is pertinent to this conversation is that we will be coming up to the end of the biennium come September. And so we were able from last year to this year transfer funds over years within the biennium. You can't do that from one biennium to the next. And so several of your institutions have one-time costs. You need to make sure those funds are encumbered, that those projects are underway. Otherwise, those dollars could be swept, and things that you thought were going to occur won't occur because they weren't encumbered. And so again, my encouragement to all of you is to make sure you're working very closely with your financial folks. If there were some of those initiatives that you needed to put in place, And for some of you, there was purchasing of some tablets. For others, there were other things in order that your staff would have a place to sit and do the T-chat services, etc. Those dollars that you had planned to put into those things need to be encumbered, and those projects need to be underway before we hit the transition from one biennium to another. Okay. Okay. Well, very good. Thanks, Sean. Anything else you need to say or any other advice?
We can.
All right. Thank you so much. I really appreciate you being part of it today. Why don't we transition to 3B and have an update from Dan Oppenheimer related to our website and the work that's taking place.
Hi, everyone. You may or may not have noticed that we have a new website. We just sort of, I think on Friday of last week, we just switched over to the new version. And I'm just going to walk you through it quickly. This is, this and just websites in general, work in progress. So there's some things that we have planned to sort of improve, but I think that I think it's in pretty good shape just as a kind of upgrade from the previous one. So the design is somewhat different. The logo and the branding are obviously the same. You see up the top, we brought this over from the previous website. This is this phone number is to I think it's the National Suicide Prevention Hotline, and then there's a link as well to mentalhealthtexas.org. You can see, and then there's this other link. This is just if you click on this, it'll auto call the Cpan number, highlight of Cpan and TChat, which are our two primary sort of external facing programs that would generate traffic to the site. There's a bunch of just kind of about information on the left. We upgraded our sort of events calendar so that it lists these executive committee meetings, but it also gives us options for webinars primarily. I mean, we can do other events if they're relevant conferences. And we're still working on sort of what precisely the procedure would be in terms of how to vet things like that that are external to the Mental Health Consortium. But these are webinars that are part of, that the hubs are creating related to, I think at this point it's all Cpan stuff, but you can see there's a little thing highlights the institution. It has registration links. If there's additional information, we can upload that. So that's pretty flexible. We're still working on that. Links to news, external news, internal news, blog posts, press releases, whatever we want. This is where we're highlighting new resources that have been uploaded. Everything that's highlighted in here is stuff that that Dr. Williams and the Cpan folks kind of vetted. We can sort of moving forward, we can also talk about how to kind of vet new resources, but it's different things like rating scales and clinical pearls and things like that. So I wanted to show you that. Right now, you can see the navigation is a little bit different. It says for providers, for schools. If you scroll down, you go to TChat. These are all these pages. These are the sort of specific diagnosis pages. These are all basically the same from the previous site. I think we're going to work on the design of that a little bit, but right now it's just a kind of recreation of what we had on the other site. Created a brief page for parents, which is just drawing when we're uploading resources. We can tag them in different ways, and so one of the tags is for parents. So it's a post on links for parents on these diagnoses. It's the model consent forms for TChat. This is just a version of, this isn't super important right now, but it's a version of our resources page filtered by keyword. So if you go here, we have all these keywords over here. You can filter by depression, and it'll highlight anything that's tagged depression. You can filter for providers. We're going to add tagging for other things like our events. So it might also bring in, if you did for providers or depression, if there's a webinar coming up on depression, for instance, it would show the events as well. And we'd have to do some design work, but we'd probably display those with some differentiation between events and resources and things like that. So this page in particular is one that we're going to work on in terms of making it a little bit more user friendly. But right now you can just, click by keyword. We're going to add something where you can select multiple keywords to filter. As I mentioned, the events page, this is also something we're going to work on, but this is the upcoming events, and then it archives past events. So that's a little bit different. And I think everything else, there's some other stuff with the navigation, but I think everything else is stuff that's ported over from the old site. So it's going to be the same. So there we are. I haven't gotten any complaints yet, though it's only been live for about a week. So, you know, I'm not assuming the best, but if anybody has any questions, as I said, we're going to keep working on this and improving it. And also as we get more traffic, that'll give us more information about how people are using the site, and that can affect you know, the design and the, you know, user experience as well. But happy to answer questions about it. That's been the main thing we've been working on since the last meeting.
So Dan, it looks like Andy had a question related to the cool interactive maps that were part of it before. You want to show the maps?
Sure. So this is the same as the previous site. If you scroll down on the Cpan page, you'll get to the interactive map, which is just the same. This is actually created in a different application, not within the site. So it's just the same embed from the previous site. And then you can download the static map as well. And then if you go to the TChat page, it's the same thing. And this is embedded from, I think Lachelle created it in Power BI. So this one is every time she updates the information on her end about MOUs in process and things like that, it's just auto uploading from Power BI. So that's going to be as up to date as we are.
And then for a clarification on this, there are some additional school districts that Texas Tech is a part of that they're under Carter, the CATR. So if you hit all, select all, you can get all the schools that one way or another we're currently part of. Hit the select all button. So
select all. Okay, so select all is going to be everyone, and then you can pick the CATR funded or the TChat funded, and then there's also, you can select MOU in place or MOU in progress, and then you can kind of see all of the coverage where we're going to be, and obviously all of the I mean, you can get down to the campus level. It's pretty robust.
And we'll have our discussions on TChat and Cpan later, but I think that map is pretty impressive of the work that you guys are doing right now and the broad reach across the state. Carol, I see your hand is up.
Yes, David, as Dan was going through what's on the website, it occurred to me that it might be interesting to put some scientific papers, some easy ones, some ones written for a clinical audience, to add them into the website. Now, I may be wrong on this because I always overvalue science, maybe, but I can imagine that some of the people, we have lots of experts in all of our networks, and maybe you want a paper or two written under some of those topics. You can tell me I'm wrong, David. It's okay.
No, Daniel, you've thought about that a little bit, and let me let you share some of your thoughts. And again, I think some of them have to do with how do you select those papers, and does it become a huge list that becomes hard to navigate versus something that's very focused. But Dan, you want to talk about that?
Yeah, I mean, sure. So first I should say, I mean, technically that's easy as pie. We're already set up to do that. We might want to, we'd have to do some thinking about how to categorize different types of things. I have ambivalence about things like resource pages because people get very excited about them. But then there is that issue that Dr. Lakey mentioned of sort of keeping them fresh. And then also in this particular instance, I think there would have to be a real vetting process. So and that's not on me, that's on you or some collection of you in terms of making sure that if we're making a sort of curated selection of research papers, that it's something that the consortium feels comfortable standing behind. So we would need some process in place. It's just hard to predict. We could do a lot of work to curate resources and research papers, and it would turn out at the end of the year or 2 years that very few people were coming to our page for that, and maybe we would retrospectively decide that it wasn't worth the effort. I mean, there are a few, we can go for it. There are, in any field, there's a few sites that become the go-to places for people to find resources, and for those people who sort of prevail in that contest, they get a lot of traffic and it's super beneficial, and it's hard to predict. I will say this actually goes against where I've often been in the past. Like there's potentially an opportunity in the child and adolescent mental health space, because I have not found a really great site that's super well organized and user friendly, that has resources on kind of child adolescent mental health. There's a lot of laundry lists, but there's nowhere. The odds are still against us, but again, a lot of that work would be on you guys rather than me, because the technical piece of it is pretty, and even the design piece is pretty easy.
So David, I would be willing to help with any part of that you wanted. And we have the whole executive committee with very many different talents and people on the executive committee who would have good perspectives. It seems to me we could do what Dan is talking about if you wanted to give it a try.
Okay, let us think about that and come back with you with some thoughts, and as part of the quality improvement, if there's opportunities there, that would be helpful. Let's think about them. I'm going to go to Andy and then Dr. Trivedi, and then we're going to need to move on because I have a speaker that's going to have to leave in just a little bit. So Andy?
Yeah, just real quick. This is great. And I want to just add, that yesterday we had got outreach from the Senate Health Committee, the Health, Education, Labor, and Pensions Committee, about wanting to highlight responses to COVID on mental health. And they had heard stuff was going on in Texas. So I walked this through with them and I showed them these maps. And so they've actually invited testimony next week, and they want to highlight this stuff. So I get to go to DC, which I'm excited about. But these maps, I think, were the key. And also the fact that like almost 2 million children are going to be reached by the time all these MOUs are in place through TChat. So I think just in terms of scaling responses, this website makes this stuff come out kind of hugely, but also people are noticing. And I think it's really exciting.
Very good. Thank you.
Nice.
Yep. Madhukar?
So I think Dan, this is wonderful, and I think what you're doing. There is one addition or one thought I had, because there's a lot of websites, as you know, with a lot of information, which is what you sound like you're struggling is how much can you put in. One aspect that may be worth thinking about is what the legislature has helped us do something very unique across the country. Our 2 research projects are really not designed to be sort of more thought pieces that'll lead us to solutions 20 years from now. These are really immediately impacting clinical care. So how we message that on this website will make it unique, because otherwise there is like 2,000 websites you can go to, as you know. And I'd be curious to see if we can figure that out. And we were actually on our network call the other day talking about this, and Dr. Martin may expand, but I think our research projects are immediately changing quality of care. And I think that is a very unique thing across the country. And so how we capitalize on that is something you may want to think about.
I think that's interesting. Yeah, Dr. Trivedi, and Daniel, I'll let you jump in. But, especially as things are written about that, there may be opportunities to highlight that or to really outline on this website how the linkage is between the research and changes that are occurring in the state of Texas. I'd love your thoughts, and Dr. Trivedi, I'd ask you to look through this and give Daniel your feedback, and I'm sure he'll be very interested in that and think through how that can be best presented. Daniel?
Yeah, and I was just going to say, I think there has been a priority for obvious reasons from a communications point of view on the Cpan in particular, but Cpan and TChat. But that is not to say that there isn't stuff remaining to do with the workforce stuff and on research, and I'm very open to that. And I've just been deferring that because I think there's been good reasons to prioritize the communications around the other 2, because they're so dependent on public participation and enrollment and visibility and things like that. But yeah, I absolutely think you're right, and I think I think that might be an interesting media pitch around the research stuff. Yeah, and I think all of this, I guess this goes to that point and to what you said, Dr. Tomingo. This is a long game, and we have time and the resources to sort of be really deliberate and strategic about these things. And when one thing's cleared out of the way, like getting this website up and running, that opens up a little bit more space for this other stuff. So I'm happy to talk to you, Dr. Trivedi, and whomever else about how to promote the research, and also about if we want to do a more we want to do this sort of publications and think through how we would curate that. Let's do it.
All right, very good. And thanks, Daniel, for all the work on moving this forward. I'm going to transition. I'm going to kind of call an audible here. I'm going to readjust the schedule just a little bit. I'm going to go down to item F and ask Dr. Alex Vo and Mary Robinson. We're going to invite them to discuss with us some changes related to the telehealth and the post-pandemic changes in health policy. We had a little bit of that conversation just a little bit ago, but Mary and Alex are right in the middle of it, and would love to hear from them some of the changes and their thoughts related to how everything is playing out. So Alex, let me turn the podium over to you.
Sure. It's my pleasure to introduce you to Mary Robinson. You may all know her in her previous role as the youngest executive director of the Texas Medical Board. So she oversaw all your licenses. She's currently the director of telehealth at UTMB, where she helps coordinate and oversee our UT Virtual Health Network. She's also a board member of the Center for E-Law in Washington, D.C., so she follows the federal regulations pretty closely, and is the founding director of the Medical Technology Resource and Education Center, or METRIC, at UTMB. It's a center designed to provide educational opportunities and training in the area of medical technologies. It was actually at one of the METRIC's conferences where Dr. Williams and I heard Mary give a presentation on the potential outlook post-pandemic as it relates to telehealth policy. So we thought it was a good idea to invite Mary to share her thoughts with you. So with that, Mary, I'll let you take over.
Great. Thank you, Dr. Vo. I'm going to go ahead and share my screen, guys, so that I can show you a quick deck here. And this is going to be rather pointed because I think that the issues that you really want to know about relate to prescribing and sort of the pandemic changes. So I want everyone to be on the same page here of when you can expect these things to roll out. So back in, February of 2020, when we were all living our best lives and there was no pandemic, that's where we were on this timeline. You can see that sort of light teal. There were lots of laws surrounding telemedicine, and there are still lots of laws, but that's where we were. When the state of emergencies were declared, you have to recall that both a federal state of emergency was declared and a state emergency was declared. The state of emergency only lasts 60 days. That's why you see these constant renewals. The federal one kind of lasts as long as they want it to last. Those emergency declarations are the only thing that gave legal authority for all of these changes that have been put in place during the pandemic to occur. So it allowed agency heads to change rules or say that they were going to exercise enforcement discretion and not enforce rules that were in place and all of those types of things. And so that's where we are right now. We're in the standards during COVID-19, that green piece. But what's going to start happening is the various rules are going to start expiring once these emergency declarations go away. And it's really important to realize that this will not likely happen all at the same time. It's going to slowly happen across lots of different agencies, depending on what they did in the interim and what that's going to look like. So I'm going to use a quick example here. Sean talked earlier about the reimbursement related to Medicaid and private pay. You should know that the law that TDI put in place to require parity for telemedicine for private pay has already expired. It expired back in December. So the payment that you're getting for private pay insurance for plans that are regulated in the state of Texas, which by the way, is only 18-ish% of the private pay in the world, in our country, in our state, that law has already gone. So what they're paying you, they're doing because they think that's what they should pay as a fair reimbursement during this time for private pay for state regulated plans. They're not doing that because they're being forced to. So, you might try to look into that to see what's happening right now with your reimbursement to give you an idea with those specific plans, what that's going to look like. but that's just an example that these things are going to fall off piecemeal in a lot of situations. If they do not take legislative action or agency level action to change the rules or the laws, we are going to go directly back to that teal area when the pandemic declarations end. Like it's in the analogy I use is it's almost like a rubber band. You know, we were holding the rubber band unstretched, and then as the pandemic happened, it stretched it out. And the minute those emergency declarations are over, it's like a release, and it's going to snap back to where we were right there. So that's the idea that you need to keep in your mind as to how this process works. If the state of Texas passes new laws, we'll go into that orange area, which is what's happening right now. And for Texas, that's May of 2021. There is no deadline federally, really. The feds can do whatever they want, whenever they want, depending on what the Congress, the Senate, and President Biden allow. So just kind of know that as background. There's always a lot of considerations when it comes to telemedicine, but I think the ones that you particularly care about are the standard of care, which of course remains the same, but especially as it relates to prescribing. So I was really asked to sort of focus a little bit about what is happening with this. So just so we're all on the same page for this terminology, because not everybody realizes the specific designations within the statute. When I'm saying controlled substance, I mean schedules 2 through 5. So for you, the important piece in there are obviously the stimulant ADHD drugs. They fall squarely within the definition of a controlled substance as far as the federal government is concerned, which means they are regulated by the DEA. A dangerous drug, I hate that terminology, I think it's confusing. That means it requires a prescription, but it's not scheduled. So please watch out for that. If you're reading something and it's talking about dangerous drugs, it doesn't mean controlled substances. So you might think that something is allowed when it really isn't. What you're looking for are controlled substances or scheduled drugs when you're talking about most of the psychotropic drugs out there. And then, of course, over the counter. So let's talk about the federal prescribing. I think y'all are getting okay, it stopped. So the DEA Ryan-Hyde Act is the controlling piece of legislation here. And it prohibits. I'm sorry. Somehow that's myself. That's myself talking. I must have somehow did a recording over this when this was my actual presentation. So what I'm going to do is just take over and I will send you this deck. But the Ryan-Hyde Act is the act that sort of oversees prescribing in a federal way. And what it says is you cannot write a controlled substance prescription for a patient that you have not yet seen in person. And Nagla, if you can share my slides, that would be great. And I can just say next slide. So while you're doing that, I'm just going to continue laying this background so that we remain on schedule. Thank you, Nagla. I appreciate it. So this means you, I guess is what I should say. When you are interviewing or treating the children in the ISD and you have only seen them via virtual connection, you cannot write a prescription for a controlled substance for that child once the emergency declaration is over. You have to see them in person at least once. However, there is a workaround to this, and that is if you sort of going into your Cpan program, if you can find another physician in the community to coordinate with who's willing to help you with that, they can absolutely write that prescription for you. As that, if you document that relationship and send it off. And then if you ever do manage to see the child in person once, which we've done with prior Galveston pilots, we would send the psychiatrist there for 1 day a month just to see the children that they needed to see to initiate prescriptions. Then you can continue to renew those prescriptions for a reasonable period of time. The law doesn't actually say how long, but in all the conversations that I've had with the DEA on this, I'm fairly confident that 12 months is a possible limit. But again, I would not go further than that, and I would document that quite a bit. Next slide, please. So The federal emergency declaration, right, is much broader. And this is presumably, if you're prescribing right now, this is what you're relying on. And it's allowing you to do it as long as you have this real-time two-way video interaction with live audio communication. And then follow-up can be done by any method. Nagla, if you could just quickly go through the next two slides. I am not going to walk through this flow chart with you. I sent it to you so you would have it, because if you had any questions about it, but that basically walks you through, if I'm a prescriber, what can I do and when can I do it? So here's the situation on what you can expect going forward. You cannot expect this to become permanent. Do not rely on that becoming permanent, because the likelihood is pretty low. We have been working with the DEA. I personally have been working with the DEA back in my old job for 7 years on this issue before I left. They have absolutely gone into state facilities. The name of the one in Texas that they did was called Spindletop, with this exact setup. It was a child psychiatrist seeing children in a clinical setting, but the child psychiatrist was only there virtually. So do not rely on the thought that this is going to be permanent. The other thing you need to know is it's a federal law. There's nothing that, sorry, can you go back a slide, Nagla? There's nothing that the state of Texas can do about this. They can pass all the laws they want, but those will not tie the hands of the DEA, and it will not change the federal law. So next slide, please. One thing, a couple of things that you should know about. Next slide, please. But the feds have tried to do. First of all, way back in 2018, prior to the pandemic, they signed the Support Act. Next slide, please. And the thing that this did in relation to you is that particularly Title VII and Title II and things like that, it really set out what they expected the DEA to get going on. For substance use treatment, they are eliminating the originating site requirements. So the idea this can all be done by telemedicine. Controlled substances can go through electronic prescriptions. And Title VII specifically set a deadline for the DEA to go in and write rules related to the Hyde Act that allowed for some way for these types of controlled substances to be written through telemedicine. It was due October 2019. No one outside of the federal government has seen a draft. And, you know, we all know what day it is. It's 2021. So my understanding, you know, and I've been to conferences and I've sat on panels with the DEA on this issue, is a couple of things. Number one, when President Trump was still in office, there was a presidential declaration that said for every rule you pass, you had to repeal two. Of course, that's really not how policy and rules work, but the DEA said, well, we can't pass a new rule because we don't have two rules we need to eliminate. That's no longer a situation, but they had, but right, the last time I saw them, which was in December of 2019, they publicly said that they had a draft available and that it was going through the renewal processes. And then we had the pandemic. So this is where we are. The federal law takes a little while to change. You can expect that from the time we see the draft to full adoption will not be shorter than 6 months. That's a good estimate. And no one has seen a draft. So that should give you a pretty good idea of where we are. Next slide, please. On the institution of all of this. And I'm sorry, Nagla, one more slide. There are going to be a lot of studies coming out related to that. One thing that the Congress has done, just so you know, and I'll come back around to this slide, they did in the most recent budget bill that they passed, the Stimulus Act, clarify that they are changing the law related to substance use disorder prescribing to allow it via telemedicine. But that is the only call out they had. They didn't change the rest of the Hyde Act. So that's still in play. Very quickly, for the Texas Medical Board and prescribing, they allow it as long as all other federal law is being met. In this case, that's the Hyde Act. But if the Hyde Act changed, the medical board rule is not necessarily going to be a problem for you, because the only thing that they really prohibit, as long as the standard of care is met, is chronic pain prescribing. And I would suspect that that's not really something that you're doing. Next slide, please. And so right now, the medical board on their prescribing has all these ways that you can do it for chronic pain. But again, I'm suspecting that's not really something that you need that much of in your current act, but that's where those laws are. Next slide, please. One more, please. There are a couple of other telemedicine laws you need to know about that will snap back. Consent and privacy amongst the forefront. The Medicaid laws that you're talking about, that you're hearing Sean talk about, those relate to primarily reimbursement and what they're going to do with telemonitoring and other types of providers who are not physicians. They cannot change the consent laws. Those are a different set of legislation, and federally and statewide. And the federal piece is obviously, everyone's heard of HIPAA. Do not bet that the HIPAA laws will change. We have gotten no indication from the Office on Civil Rights at a federal level that they intend to fully change the HIPAA laws. In fact, we've gotten the opposite, which is them sort of saying things like, you should really be thinking about getting onto a HIPAA compliant platform if you haven't done it already. Because honestly, their rules, more so than any, didn't change at all. They just entered what's called enforcement discretion, which was them saying, hey, we know our rules are still here, but trust us, we're not going to enforce them during the pandemic, which means they will start enforcing them again once the emergency declaration is over, or once they feel that it's reasonable to do so. They don't necessarily have to wait for the emergency declaration to be over. They can, but they don't have to. And a lot of the noise coming out on that is that any day now, they're going to say, you need to be on a HIPAA compliant platform by X time. So I am guessing that the vast majority of what you use is HIPAA compliant, but you really do need to make sure that that's the case. Even the emails that you're using to schedule appointments or texts or any of that stuff, any of the communication surrounding your patients need to be done in a HIPAA compliant way. Those flexibilities, I would say it's like a 1 in 100 shot that any of those continue. Consent is a different matter. I fully expect that consent will still be required, but there's a lot of clarification work going on about what's required to make sure that we have consent. Some of the agencies in the past used to have a perspective that you had to write it out, you had to sign it in person. That's all, I think, going to go away. They're clarifying that, look, consent can be done electronically. You don't need to do all of those things, but you will still need consent. So again, if you haven't built consent into your processes, I'm sure you all have, I'm sure you have all the documentation, but if you in your private clinic don't have that built in, really think about doing that right now. The same with the notice of the complaint process. I do not see that medical board rule going away. If you don't have a notice of complaint process somewhere within your electronic process, you need to make sure you have it. So be thinking about these as you're coming out of the pandemic. Next slide, please. And I did talk about this, but also beyond security, you also need consent for HIPAA. If you haven't done that, make sure that you're figuring that out electronically. Next slide, please. So I've summarized these changes here for you for when you can expect them or what the differences are. Next slide, please, just so that you have them. I'll just quickly touch on licensing credentialing. Next slide, please. And then I will go ahead and take questions just to stay on track. Remember that the care occurs where the patient is located. If you somehow pick up a patient through this system and you want to keep them after they leave the district and they are traveling with their family, you have a problem if you are not licensed to practice medicine where they are. Now, there are states that have consulting exceptions. There are states that have temporary licensing exceptions. Make sure that you know where your patient is if you're not treating them in the school, because patients have a bad habit of not telling you. in your private practice, make sure your patients know that they need to disclose their location when you treat them. Because if they decide that day they want to drive to Louisiana and they're going to stay with their mom there for 6 months, and you're treating them, you don't actually have a license to treat them. And actually, that's not even a pandemic thing, because almost all states require some, even in the pandemic, some sort of temporary license or registration. So be careful about that. Next slide, please. These are the exceptions for licensing during COVID. I just put them here so you would have the resource. Beyond licensing, there's credentialing exceptions through CMS. We're hoping that CMS will do something with this more permanent. The idea being that if you are on a CMS provider group, you should be able to kind of go to the other CMS provider groups. That may happen, but it won't happen on a state-to-state level. Next slide, please. Really quickly, I want to say that this may be the year the compact passes in Texas. If this does happen, that's great news for you, because then if you want to see patients who are in another state, once you join the compact, you can see them in any of the states that are dark blue. And as you can see, that the number of states that are not joining is really becoming minimal. So that problem will go away. If the state of Texas does join the compact this time around. It has had its hearing, it has passed the House, it has been received in the Senate, which is the best place you can possibly be in right now. So this may happen this time. Next slide, please. Last thing I want to say, and then I'll take questions, is, and I'm sure Dr. Lakey is keeping you up on this, is the big broadband push. It really does look like this is going to pass. It's obviously going to be attached to the University of Texas system. I'm sure there are folks there that have more information about that than I do, but this really will sort of throw open some of the doors for the last areas that we have been unable to reach. So it will be interesting to see how this plays out and how this folds in with coordination across the different agencies like the EHAC committee and all those things at HHSC. And I'm happy to take any questions. Thank you, Nagla. That's it.
Very good. Dr. Trivedi.
Thank you very much. That was wonderful. Quick question. Is there any talk about how to deal with the substance use problem? Because as you know, the treatments for opioid epidemic is actually increasing, and yet the treatments for those like methadone and buprenorphine, access is a huge problem because people have to come every day, for example, with methadone.
Sure.
Is there any thought about allowing some easy access?
Yes. Honestly, the way that Congress is acting right now, and this is the language that passed in the last 2019, I've forgotten the word, the thing where we all got checks, the thing where they were trying to boost up the economy, that last sort of
stimulus.
Yep, that act, they absolutely called out substance use disorder and medication assisted therapy as something that they are going to create an exception for. That almost assuredly will happen. They almost assuredly will create an exception for allowing that type of therapy to happen at home and for allowing those types of drugs to be prescribed in any setting without the necessity, possibly without the necessity of an in-person visit. There is a lot of traction on that particular piece of it. There is not much traction at all for all the rest of the controlled substances. Because exactly, and the thing is, the factor that is allowing both those things to happen is the same, which is the opioid pandemic. So the DEA's position is, look, it's hard enough for us to keep a lid on the opioid pandemic to the best we can already. If you open it up to where anyone can get it through any portal and there's no limitations on that, we're telling you right now, we can't do it. And so also because of the way the Hyde Act was written, the whole act is just written to prevent these types of drugs being given. So the DEA can't write an exception that says all controlled substances can be written via telemedicine, because the only thing the Act says is controlled substances cannot be written and billed via telemedicine. So they have the ability to create an exemption for telemedicine that is narrow. What we've been arguing with them, or what I have posited to them over and over again, is let the states be your partner in this. Create an exemption for patients that are located in any facility licensed or overseen by the state. That would bring in all your long-term care. That would bring in all your ISDs. That would bring in all your hospitals, all your treatment facilities, all of it. But again, we don't know what's happening with that because we're not seeing it. But for your medication-assisted therapies, yes, I think you have reason to be optimistic about that, because they have specifically called them out, not just in the Support Act, but in the Economic Recovery Act of 2019.
Okay. Any other questions for Mary? Seeing none, Mary, really appreciate the update and all the work that you're doing, and obviously something we need to keep track of as we continue to move forward. So again, appreciate your time, and thank you, Alex, also.
Thank you, Dr. Lakey.
Thank you, Mary.
Alex,
and if anybody has any follow-up questions, please feel free to email me. Thank you so much. Bye-bye.
Yep. Very good. All right, I'm going to jump back up to item C, and Dr. Lopez, I think I saw you a little while ago, and be great if you could give us the update related to the program evaluation work that you're doing.
Absolutely. Thank you so much. So it's been a busy month around the whole issue of data as we think about the consortium broadly. We've put together a number of different tools that are intended to that is outside of the trait system, with a few more to come, but many of those tools were launched over the last month or 2 months. One of the most exciting things that I think we've launched in the last month is the family and student surveys for families who are involved in TChat services. And so we have those available now in English and Spanish, and the HRIs are utilizing those surveys at the end of the brief services during TChat. So we will have that additional information coming in, which is going to be very exciting, I think. And a huge shout out and thank you to UTRGB for supporting the translation of that, those two surveys. We were also able to complete the final qualitative interview that I presented on at our last meeting. So I wanted to sort of let folks know that all of the HRIs have had opportunities then to weigh in on their lessons and accomplishments and recommendations for moving forward. And then the other thing I wanted to do really quickly this morning is to share a few things from the TChat school enrollment, which seems very fitting since we talked earlier this morning about some of the maps and some of what's happening in terms of those campuses and their coverage across the state. So I thought I'd share a few updates on that. So this is based on data that we've received as of April 15th. So it's a little bit different than some of what's on the map, but pretty similar. So overall, these are completed MOUs with school campuses, as you sort of saw in that drop down. We have 158 districts currently enrolled with our HRIs, and that covers 1,700 campuses across the region. And we have covered lives of over 1.2 million, which if you were interested in sort of what that covers of the overall student population, we are at over 23% of the students in Texas now covered through TChat. This is kind of a look at the growth over time. As you all know, the initial months of the calendar year were really focused on getting contracts out and established and things like that. But you'll see starting in May of 2019, that's month 9 here at the bottom, is really when we started getting all of those MOUs up and going, and we've had really dramatic increases over that time period. It'll be interesting to see, what next year looks like, but we've noticed the biggest leaps seem to be in that summer months between June and September. And then we also had some pretty big leaps in the January to February months. So when schools have a little bit more time, I think sometimes to make some of these things happen. A little bit about the campuses that are enrolled. And here you'll see we've got two different parts. On the left-hand side are both our TChat and our CATR campuses, which we talked about earlier, are the similar campuses that Texas Tech has enrolled. And then on the right-hand side are those campuses that are not enrolled in either TChat or CATR. So you'll notice this is about kind of community size. Each of the campuses are classified on 4 categories, whether or not the communities represent more cities, rural, suburban, or town, which means kind of near urban areas, but not suburban, kind of outside of those urban areas. And so you'll see there are a few differences in our current campuses, a few more that are considered urban areas, a little bit fewer that are considered rural, a little bit fewer that are considered a town as well. So just a little bit of difference, but you can kind of see that spread. Also looked at the proportion of students within each of the campuses in terms of whether or not they've been classified as economically disadvantaged. So you'll see here, again, on the left-hand side is our TChat and CATR campuses. And you'll notice there's a greater proportion of students who are considered economically disadvantaged in our TChat campuses right now, compared to our non-TChat and Cater campuses. Another thing that TEA provides is information about students at risk. That is a bit of a complicated grouping of multiple risk factors that go into that. So things like experiencing homelessness or involvement in child welfare systems. So it's a variety of different things. But you'll see we have fairly similar rates, a little bit more of a proportion of students at risk in our TChat and Cater campuses than our campuses at large. And then the last item that I was kind of pointing out in here is the proportion of students who are identified in special education across our campuses. And you'll see they are exactly the same, with 11% of those students identified as in special ed. So lastly, I just want to thank the group for helping us keep those lists updated. I know it's a big ask, but hopefully you can see the value in it in terms of the value that's coming across on the website as well. And I want to kind of let folks know if they're interested in us providing kind of this type of information for their region, looking more specifically about the campuses and how they compare to the other campuses within your region. We're happy to do that. I think by looking at some of those characteristics, it gives us a chance to perhaps do some targeted outreach to districts based on whatever characteristics you might value in how you target and enroll districts. So that was all I have, and I'm happy for any questions.
Molly, I see people cheering you on, but I don't see anyone raising their hands yet for a question.
Well, I think it's cheering on the HRIs and TChat for what's happening.
I'm curious, Molly, is that a Power BI presentation?
Nope.
Nope. Okay. It looks like, okay. Well, it looks great. It's even better then.
All right.
So I have a quick question.
Go ahead, Dr. Betty.
This may be a sort of too ambitious, but is there a way to think about it going forward to see if there is some level, kind of population level or epidemiological level impact of this that we can begin to document? Because we are covering, say, 20% of schools, then that area could potentially see improvement in rates of depression, suicide, anxiety, hospitalization, etc. Is that maybe hard to think about, but worth considering as you move forward?
I think that's a really good point, and I think would be a great opportunity for discussion. Some of what's available through the TEA data are things like disciplinary referrals, things like that, which we may or may not think are adequate outcomes, but unfortunately, we don't have very good data. For example, the YRBS, the Youth Risk Behavior Survey, is something that is collected in the state, but we don't usually have it sampled in a way that allows us to kind of get to regional data, which would be an ideal kind of way of tracking some of this. So I think it's a good discussion, and we should keep thinking about it.
All right, very good. Any other comments or questions?
I have a question. I'm thinking forward. So we're covering about 23% of the campuses in the state with current effort. I don't know about other HRIs, but we are, at least in my area, in my HRI, we're maxed with the T-chat. We need to expand more, hire more people. We use all the funding that we have and got more schools signed in as possible. So my question is more toward the direction. One question, of course, what Madhukar said is critical, is to demonstrate that that moves the needle. The other question is, let's say it does move the needle or not, or we cannot answer that. What is the general thinking that we as a consortium have to kind of engage? Do we want to demonstrate that we're improving our kids or the kids who we enroll, or we want to argue that we need to expand? And that means basically, at least for those particular programs, doubling or tripling the amount of work that we are taking ourselves to try to cover 60, 70% or 80% of the campuses.
Israel, I guess the one thing that I would say, having grown programs when I was at DSHS, is that there's multiple factors that you have to consider. You have to look at need, but also you need to look at what can you realistically do. If we were to say that we were going to now be everywhere, could you really hire that number of psychiatrists and mental health specialists to really do that? And a lot of those type of things have to come in to make sure that we have realistic growth year over year. But I think it is the desire of the legislature that we do more. We need to make sure that we fully use the resources we have right now and maximize them in every HRI and see what that level then is, and then what is realistic as the next step. But I don't think it's going to be realistic to say we've covered a quarter and next session we're going to go to 100%. What would happen is that we wouldn't fulfill that because we couldn't hire the people and get the MOUs in place and everything else. And so a stepwise progression, I think, is the pathway.
So
does that make sense?
Yeah, it does. And that's exactly my question was, I think we need to, this is a great data. And one point that Madhukar brings up is very important, is to be able to document how we're making a difference. And the other thing is, if that's the situation, what's our projection vis-a-vis growth, or how we have to think about it. So that will start a lot. At some point, we should be able to start modeling and say, okay, if we have so much more access to the providers, we have more providers, we have more money, we can get to those numbers. If we have run out of providers, then how do we do that, and what do we do? How can we use our resources? So I think it's a great beginning where we are. And the question is, now we can start making more longitudinal planning from our own perspective, and then presenting it to the legislation and so on.
Very good. Dr. Keller?
I think the other thing to keep in mind on that, and those are really good points you both are bringing up, is Cpan was always designed as a statewide service because it's the only thing like it. TChat was not. TChat was really designed for schools that didn't have other services. So there are quite a few schools that have pre-existing arrangements with local mental health authorities, with FQHCs. For example, in Houston, there's quite a few FQHC relationships. So there's a lot of school districts that are doing other things. So I think that It's just, it's a different sort of, so it doesn't mean we shouldn't be doing what you're talking about in terms of looking
How'd it
for
go?
other opportunities to expand. But we just need to keep in mind that it was never really the mandate of the consortium to serve the entire state with TChat. It was really for schools that needed that. And I'm sure there are more that need it, but it's not the whole state.
$18,000.
I'm going to ask folks, there's a couple of folks.
Yeah, but does that mean that it's totaled, or do they, he doesn't know yet?
Yeah.
Okay.
Yeah. So.
Tanya?
Okay.
I said, well.
I would ask folks to mute their lines.
Yeah,
if
I
they're not
mean,
talking right now.
that's why I'm trying to get you to think about that ahead of time. Like, one way to deal with it is they'll still let you keep the car. They'll just total it out. It's a, it's a salvage title.
Tanya, you have a live mic going on.
Look at taking the money and getting it, like the place that they were talking about in Fort Worth.
John,
but if you're not able to get full coverage.
Can we mute?
If there's an accident
John,
when you have a salvage title. So, I mean, Jenny, I like to think about things ahead of time. I don't like to wait till, everybody else.
Please mute all.
You know what I'm saying?
Okay. All right.
I ate a piece of pizza. How did it go with the thing?
Okay.
How did it go with the?
John, please mute all.
Did they give you a sheet to show you what it was, and was it out of alignment?
Well, it was adjusting, I guess it was.
Oh, they didn't show you on a sheet?
Yeah, it's in the car.
Oh, okay. Normally they'll show you and it has.
Hey, David, does the host have the ability to mute her?
That's what I'm trying to get one of our folks to mute all.
Because she's probably
she can't hear us.
I don't think she's here.
I got my appointment at 3:30.
Nogler or John, if you can mute all, that would be good.
I gotta take this, Jenny. Hey there. Hello?
Sonia, can you hear us?
No.
Sonia?
Mute.
Okay, I'm sorry.
Thanks to that. All right, let's move forward then and go to item number D with the research initiative. Dr. Dominga?
Yes, I think for the research initiatives, both Dr. Trivedi and Dr. Nemiroff have presentations. I bet, Charlie, why don't you go first, and then Madukar, you can follow.
Okay, do I have the ability to share my screen? Is that okay?
Yes,
while he's figuring that out, I'll just say that the recruitment is going really well. And it looks like the recruitment is going to be on, it's going to be able to be on track for finishing up by the end of this year. There we go.
Can you all see my screen?
Looks good.
Okay. Well, I'm going to be very brief, but I'm incredibly proud of the entire network. We have are up and running. All cylinders virtually are firing, and I'm going to show you some exciting results. And I'll ask Dr. Wagner to weigh in when I'm finished with the presentation. But here is the enrollment. We have enrolled 418 subjects. As you can see, 386 baseline visits. We've already done 258 one-month visits, and now we're just beginning the 6-month follow-up. And this is the enrollment by site. So we got through a lot of IRB issues at individual HRIs. So a couple of folks like Lubbock and Tyler are still not enrolled any subjects. And we've had a race between UT Southwestern and UT Austin. And Southwestern was ahead until last week, but we surged ahead, Carol and Madukar, on the trauma network. So we've reached more than 100 enrolled subjects, and you can see that there's been just tremendous activity. So I just want to particularly highlight El Paso, which was a very late starter, has done phenomenally well. with 30 recruitments. You can see UT Houston, San Antonio, and of course, UTMB has done well as well. So 418, really terrific. This is a breakdown of the visits per site related to the baseline visits in blue, the 1 month follow-ups in orange, and then at the very top are the just couple of 6 month visits. We've had 4 at Galveston and 2 at UT Houston, and then you can see the sort of scorecard at the bottom of the slide. I knew you would be interested in the demographic distribution. So looking at ethnicity on the left and race on the right, and I've listed the US Census estimates at the bottom for you to compare about how well we're doing in representing the state of Texas. You can see that even though we've only recently had the IRB approve the Spanish version of all of our instruments, 39% of the subjects recruited in the trauma network are of Hispanic origin. That's larger than the 32% US Census estimate, and 52% non-Hispanic, 9% unknown. If you look at the right side of the slide, it's really quite interesting. So 61% white, 11% black, which is close to the estimate for race distribution in Texas. We're exceeding the estimate in the general population in terms of Native Americans, 3%, multiracial, 14%, unknown, 9%. So we're really quite pleased. We think on the left side that we'll probably get a pickup in the Hispanic subjects now that the REB has approved the Spanish translations. This is really quite an interesting slide as well. We're looking at sex assigned at birth. We're seeing a relative predominance of females versus males. Remember, we're recruiting in the relative immediate aftermath of trauma. And then quite interesting, we're looking at gender identity. And this is actually a bit of a surprise. So 63% identify as cisgender, 3% as transgender, 11% as other non-binary, and a third did not disclose their gender identity. And you can see that here on this slide in terms of the numbers. You see we have more trans male than trans female. And here's the other non-binary numbers, but a large number of individuals, about 125, that have chosen not to disclose their gender identity. In terms of age distribution, we're really checking all the boxes. You'll recall that we're striving to recruit children, adolescents, and young adults 8 to 20, and you see the distribution. We're really getting a wonderful distribution of prepubertal children, adolescents, and young adults. A little bit, the average would be a little bit less than what Maduka is seeing in the Youth Suicide Depression Network. In terms of the traumatic experiences, that's the index episode that gets them recruited into the network. You could see those that are the most common are having a family or friend member injured, having surgery or being hospitalized yourself, having an accident, and then of course, the more traditional psychiatric trauma, including bullying, which you see on the right, and cyberbullying, as well as sexual abuse, accident witnessed, and then a variety of other miscellaneous traumatic events. This is what we had hoped for in terms of having a panoply of different kinds of traumatic events. This has been the biggest surprise to me, and it might be to you. This is data related to what is the primary psychiatric diagnosis in the immediate aftermath of trauma? Now, remember that the whole goal of our study is to determine what is the trajectory to developing either PTSD or substance use disorder or depression after a traumatic event. But what we're finding are a large number of children and adolescents who already at baseline fulfill diagnostic criteria for PTSD, for major depression, ADD, a relatively high number of children with autism, and then a variety of other disorders. And obviously, we're going to be tracking this. Most of this is due to past traumatic history in the PTSD population. If you look at what are the traumatic events associated with a baseline diagnosis of PTSD, and they're shown here in orange, the most highly significant ones are, and there's no surprise here, physical abuse, highly significant, having a family member jailed or taken to prison, sexual abuse, bullying, and cyberbullying. And then I thought you might be interested in those individuals who already fulfill criteria for PTSD. What is the relationship to their relationship to the perpetrator of violence? And you can see for physical abuse, it's most often a relative or an immediate family member. For threatened violence, it's a relative or immediate family member. And for sexual abuse, it's a relative. So we're very excited. I'm going to stop sharing my screen and be glad to take any questions, or perhaps I'd ask Dr. Wagner to make a comment or two as well. She's been a wonderful co-leader.
So I think what you've all seen is that the network is truly thriving, and it's an incredible group of investigators that have come together to gather this data in what is a remarkably swift period of time. And what we're getting are a fabulous representation of children and adolescents in the state of Texas. We have, as you can see, so much diversity, and it's covering all of the major forms of trauma. So the network is so unique, and it's just, if some would say it would be almost unimaginable how that many children and adolescents could be recruited in such a short period of time. So with all of this, it's going to enable us then to move forward, learning a lot more about them and think more about treatments for these disorders.
You know, I would just add, Karen, that even for those of us in the trauma field, the magnitude of the trauma we are seeing is extraordinary. And fundamentally, and Carol is asking the right question, most of these individuals would never get evaluated and be referred to treatment. And I think that's one of the really take-home messages for the legislature. But the magnitude of the trauma, there is no other state in the country that's doing this. And this will be the largest cohort of children and adolescents that have been victims of trauma to ever be studied anywhere in the world.
Dr. Escamilla?
Yes, just wanted to commend the leaders of this particular research study. Especially, I really appreciate your efforts to include all the schools across, all the medical schools across the state. I think that's really helping us to get a representative sample and to really make this a unique study. And the second thing related to that is you guys have done a great job in making sure this sample is representative of the state of Texas. And that is rarely done in research studies. So I think that's a real kudos to you guys for making that an important part of this.
Well, Michael, you have been an integral part of the team, and I want to reach out and shout out to Israel and Jair, to Jeff Newport, who runs operations, to Carol for her support, and of course to Karen, because this has truly been a HR wide effort, and really couldn't be prouder.
All right, very good. Thank you, Dr. Nimroff, and congratulations on the progress. Let's now go to Dr. Trivedi.
Let me share my screen. Can you see my screen? Are you able to see my screen?
Yeah, yep, we see it.
Yep, looking good.
Wonderful. Thank you. Thanks, Charlie. I think that the short, that was very good, very thorough, and I'll be brief. This is sort of, we have the same story, and we actually gathered together also, so we're helping each other. So thanks a lot, Charlie, and I'll be brief because there's a lot of overlap. As you remember, we were really charged to try to stand up a research network, train staff across the state, develop a youth depression and suicide registry, and collect this information longitudinally. And I'll talk a little about the longitudinal part because I think that is really the key difference across the nation, that nobody has really done that. So fortunately, we now have all the 12 nodes stood up, and I'll give you just a rundown on all the tasks we have already engaged in. Those really have gone wonderfully, and patient participation is ongoing. And I'll give you the numbers. We have had a fully functioning data team, and we've had multiple conversations with a lot of people in the network so that data will be available. The clinical operations team regularly meets, and the full hub team regularly meets in order to try to make sure that the project is going as planned or even better. I think we have fantastic, and I think, Charlie, you absolutely summarized it at the end wonderfully, and that is all the 12 HRIs are now recruiting, functioning, and all have trained staff. The number of people who have been trained and certified, really, at some point, Charlie, we should also try to kind of convey the other reality of both the networks is now in state of Texas across 12 HRIs, we have now research trained and research certified infrastructure that can actually take on any research study we want to do. It is actually beyond the study we are already doing. For example, we have over 50 assessors trained and certified that makes it easy for us to do a large study anytime anybody wants to do it. And that's really our focus in the next 6 months, to put on more studies if people can get external funding. We have regular meetings, and I can give you all the rundown, but I think each time there is a functioning meeting that goes through training, certification, assessor training, as well as inter-rater reliability trainings, in order to ensure that not only are people trained, but certified and continuously quality improved. The other big accomplishment for the network has been a fully functioning measurement-based care and collaborative care training module that is now implemented across the state, and I'll show you some of that. And maybe if we have a little time, I'll ask Dr. Martin to at least give a little primer on what she saw using this measurement-based care. That is the kind of thing that normally doesn't happen in routine clinical practice, and I'll show you some of the data also. So we have these regular trainings that are ongoing, and people can participate. The REDCap data tracking system is functioning with the dashboard, and the communications across the network are in many different forms, including Slack. So we have, as we heard from Dr. Robinson, the COVID pandemic is changing the way we communicate. Well, we have now many different ways of communicating that are all functioning. The dashboard is now a live functioning dashboard. Anybody can go and see what is going on at each site, etc. So data-wise, I think that I'm going to give you a little bit of a sense. We have now extensive assessment battery, and that includes not only diagnostic criteria, but variety of symptoms, both from parents as well as from the participants, children, adolescents, and all the way up to 20. We are also having a lot of crosstalk between the two networks. So we are measuring trauma as well and collectively together. So we'll have data actually across the two networks that can be compared. And we are looking at a lot of aspects of this. And this is a real shout out to Stephanie Bryan from that. We really focused a lot on also assessing strengths and resilience for these participants, and we'll have data on that, because not only looking at what is troubling them, but looking at their strengths and resilience is really important. So we have measurements on that. We have developed a fairly extensive amount of recruitment materials we submit. Give you an example of the measurement-based care implementation. So this is an example of a data extraction as of April 12, where we extracted data from 106 participants to identify whether they did get measurements, yes or no. So a very small proportion of people, kids getting through the clinical practice there, do not get measurements. I think if you show this data, and Karen, I'd love to have your comments on it, at the annual meeting of the Child Adolescent Psychiatry Group and said that is what we are doing, that 93% of kids going through are getting measurement-based care, that would be different from what is happening in the nation. And the most majority of them are actually getting PHQ-9. Some of them are getting other measurement tools. There still remains a small group of clinicians that are using clinical assessments as interviews, but I think that is absolutely within the realm of what you would expect for any guideline-driven care. Not everybody is appropriate for a guideline-driven care. But what we are seeing is 100% of the kids going through that are getting measurement-based care and collaborative care that participate in the research study. We have regular committee meetings, and so shout out to all of the partners and Israel has been helping us with extensively with a number of things. So has Dr. Escamilla. Dr. Garza is also really very actively helping us with the recruitment aspects. So we have 466 participants who have consented. We have completed around 1,500 study visits. As you can see, all the nodes are recruiting. Some of the nodes that had initially had to take some more time through their IRBs, et cetera, are now fully online. And I am very confident that in the next 3 to 4 months, all these bars will be on the same level. And we are really thankful to all the ones that started early, and you can see the numbers. And this is only beginning, in my view. And again, Michael, Dr. Escamilla, we were talking about this on the network call. Our IRB for Spanish-speaking participants is now almost approved. We have found a couple of final things, and as soon as that is in place, we will get even more play with participants who speak only Spanish. So we have majority of our participants, as was planned, are in the 12 to 17 year age range. But we are, thanks to Dr. Liberzon and all of the NET executive committee that asked us to go up to 20. We have about 20% of participants who are in the 18 to 20 year age range. We are, as you saw with the trauma network, we are getting 45% Hispanic participation. Obviously, this will immediately jump as we get to the Spanish consents, and I'm looking forward to that. We are getting a very good representation for racial diversity. And as you see in the national figures, as Dr. Nemiroff showed, we are actually besting that rather than only trying to chase the numbers. So we are getting a very, very good representation. Obviously, we can still expand further, and we continuously work on that. Clinically, I think this is the real issue, and that is the participants are really, so about 70% of them are moderate to severe depression, and these people may really most often don't even get into treatment, or they get into treatment, they don't get measurement-based care. And you can see that this is really the most severe population. This is the group of people, if we, that's why I was asking Dr. Lopez. I think these are the people, kids who, they are in school, they're not able to perform as well and need treatment. Same thing, about 60% of them have severe anxiety. The most interesting and in fact, in some ways, place where we really, as the network, but even as a society, need to pay attention to is 23% of these participants are actively suicidal at study entry. That is a significant rate, and if we look at their comorbid diagnosis, about half of them at least have 3 or more diagnoses, and about 24% have 2 or more diagnoses. So this is not their first brush with depressive symptoms. This is a group of participants we are getting who have actually a number of comorbid diagnoses. So this is the severe of the severe group. And you can see that even reflected in this. About 49% of these people going in, our participants, have attempted suicide in the past. Again, another moment to pause. I mean, this is not a mild unhappiness. This is real. You can even see that even in just the past week, 5 of the participants attempted suicide. There is a huge amount of suicidal ideation. Not surprisingly, these are people with depression, but a large proportion of non-serious self-injury also. So this is really where their hopelessness, helplessness, and their self-esteem is so affected, they engage in self-injury behavior. As Dr. Nemerov showed, I think that you can see this, the range of traumatic experiences the people experience. And Charlie, as we are also seeing the same thing, the sexually abused is much more associated with the diagnosis of, and physical abuse with diagnosis of depression. The services used, the lifetime and current, you can see there is a very large proportion of the participants have had at least psychotherapy, medication, family-based therapy, etc. So I'm going to stop here. I can provide more data, but I think that Dr. Wakefield is not here. So maybe any thoughts from you, Dr. Liberzon or Escamilla, and maybe Dr. Martin, you want to give your example of the anecdote if you have a moment. I'm going to stop sharing.
Sure, I could do that. I included it in my slides too, so I'm not gonna. I won't make.
Okay. So then
I won't make you do it twice. So maybe it's better I say it now.
Okay.
So in one of our research meetings, Dr. Nemerov and Dr. Trivedi both asked me to share a story that I had shared during the meeting. So I had a patient who is in the depression and suicide study. One of my patients, I think I've known her since she was 8 years old or something. She's a teenager now. And she was identified by one of the research assessors as having, of course, there's a certain level of suicidality. You have to contact the PI, and then we make plans for the safety of the patient. And so they called me, and especially, and then I'm also just happened to be the psychiatrist for that patient. And the teenage girl had told the research assessor that she was having more and more suicidal thoughts. And so I called up the mother and talked with her about it. And the mother was like, well, I don't know if we should do anything else. And I gave her some options of partial hospitalization and at least going to a hospital for an assessment to see if she could qualify for a higher level of care. And she's like, well, but I think she's doing okay. But then she also had another appointment with her therapist that week. And I think that having gone through all these suicide questions and I had actually had another appointment with the child too. So it not only did it allow the child to start talking more about how she was feeling, but it helped the mother understand how that even though she might be still doing the things she does every day, doesn't mean she's not thinking about dying. And nobody wants their child to be thinking about dying. So then the same week, she had another appointment with her therapist. So again, the child was able to discuss it with the therapist. And so once that like fourth or fifth discussion happened with the mother, that was all spurred by the research study. She went into partial hospitalization where she's been for the last 4 to 6 weeks, somewhere around there. She's doing much, much better. And the mother is happy and she and the child is happier. So it was just, I think the reason the two of you like to study it brings research back to the actual patients that we see and to an actual individual human that we felt. So that's my story.
Thanks.
Nice to share, Sarah.
Thanks a lot. Israel or anybody else want to make a comment? It's been.
That's a hard act to follow. I think we all have to appreciate being a physician, what it means to make a change in a child's life or any patient's life. And if we can contribute to that, that's the best feedback that we can get. So I just appreciate that.
Well, very good. Thank you, Dr. Trivedi, and thank you, Carol, and Dr. Nemiroff, and everyone else that's been part of this.
Thank you, David.
Hearing how everything is moving forward. We have a lot to do on our agenda, but I'm sure that after going for 2 hours, so some people need a biological break or to grab something to drink or grab something to eat real quick. And so I'm going to call an audible here real quickly and let you know that I'm going to take a break and we'll resume at 12:15. We will need to move then quickly through the rest of the agenda. We still have several things we need to talk through, but I think everyone probably needs a quick time to, even if you just need to stand up. And so I will call us and convene us again at 12:15. Thank you. Hello, everyone. This is your 1-minute warning. We will be starting again at 12:15. We're going to be punctual. That's all your thumbs up, Mark. All right, it is 12:15. Why don't we go ahead and resume? Again, we still have many things to do. We have about 2.5 hours left. So I'm going to, again, encourage folks to make sure we are moving forward efficiently. But again, a lot of important things that we need to talk through as the consortium leadership. So with that, why don't we go to the update from the external evaluation from UT Health Science Center School of Public Health and Dr. Savas and Peskin. Let me turn the virtual podium over to you.
Great, I'll start us off. And you may see recognize some of the data we're showing you because in our last meeting with you all, we mentioned we were having a hard time getting data from to cover some of our goals, and we were very successful in meeting with stakeholders who are working on building databases to support evaluation and implementation of the program. And so we were we met with them and we developed a system where we can understand the databases and then guide us being able to extract data and build our REDCap database. So this is the, oh, we have slides. Should I be sharing my slides or was someone going to pull them up? Sorry.
I can pull them up, Dr. Savas, if you'd like.
Okay, I could have pulled them up. I just was going on autopilot here. I don't mind pulling them up if that helps. There we go. Yeah, that will make more sense to you. You can go to the second slide if you want. So we're really spending some considerable effort in building that infrastructure that will support the surveys that we're sending out to players in the clinics and HRIs and at the school levels, and also creating our infrastructure to select a diverse group of organizations that we can interview for the process mapping. So that challenge that we identified last time in terms of obtaining that enrollment data in the clinic, the PCP enrollment, school district enrollment, we've solved. And so I think that that's a huge success. And we got to see how everything's coordinated and communicating the building of those infrastructure. And it was really great to be part of that discussion. So we really appreciated that. You can go to the next slide if you want. Yeah, so I'm about to show you some maps of clinic enrollment for Cpan and then also the school district enrollment. And the one take-home message of these maps is that we're freezing the population of clinics and districts as of March that we'll be using as our framework to select participants to interview and to do the process mapping so that we are able to capture organizations that have a chance to do some implementation. But we are, at the same moment, we're also going to continue building our maps to be able to describe reach and coverage. So if you want to go to the next slide, you can see this is the active Cpan clinics over HRA region in Texas as of March. And I know that you continue to enroll, but you can see that the active Cpan clinics are 656, and the total Cpan clinics reached includes those that are pending status of agreement included. So we're using the total. We're including the total, which you're seeing distributed here. If you go to the next slide, you can see that we've mapped this on to a vulnerability index. This is a CDC composite measure. It's an index of vulnerability that we're able to see the distribution of where these clinics are. In our surveys, we'll get a lot more factors that we want to examine. That's part of our outcome evaluation to understand different characteristics, different implementation models, population served. Those we'll get from our surveys, but you can see these are going to be kind of the starting point. The SVI score we'll talk about a little later, but that also guides our selection of who we're selecting to survey and do process maps with. If you go to the next slide, you can just see this is how they're represented and who's included right now. And in terms of clinic practice, so pediatric practices versus family medicine, you can see there's a fairly good representation there. And then the agreement status as of the time of those included in our database. And this is again to show you kind of the baseline of who's going to be part of the evaluation in terms of surveys. And if you go to the next slide, is just a little more information on what this SVI is. This is the vulnerability index. And so to not oversimplify vulnerability, it takes 15 different points that can be modeled spatially. And this is including socioeconomic status factors, minority status and language, household composition, disability, and then another category is housing type and transportation. So this is a composite score, and that's what you saw modeled on those maps in terms of characterizing populations that the clinics are based in or the school sites as well. And we'll continue examining these factors on an individual level, but this was our ecological approach to being able to look at communities with existing data. And if you go to the next slide, you can see in terms of TChat that these are the active TChat campuses. And then the again, with the active district campuses with signed MOUs, and then the total is those signed or pending MOUs. So you can see they're fairly concentrated around hubs. Right now, our plan going forward is we're also going to look at this by HRI so we can see how, give feedback on enrollment and the distribution of clinics and schools included as more enrolled, similar to what you saw in the maps that the internal evaluation was showing you. And if you go to the next slide, you can see the active campuses over counties by that SVI score. So this is, I'll just make a side comment here that the success of being able to use the same data will really help us all understand the data and also that there's not confusion of how we operationalize something. So it's really great that we all are on the same page with where we're getting our data from. So we don't have different comparisons. This is going to make it so much easier to interpret results because it'll be comparable across internal and external evaluation, which I think will be really important. So this is, please interrupt or ask questions if you want. This is just, again, mapping out who's right now in the universe of enrolled so that we can start conducting our surveys, which Dr. Peskin will talk about later with the school districts. And if you go to the next slide, this is the TChat districts as of March. And in TChat, these are the TEA district types, and then the covered campuses by district MOUs. And we'll compare next time how this compares to the total in TEA, because this is right now the total enrolled in TChat. But when we looked at it, just eyeballing it, and it's really, because we're aggregating, it's not, it doesn't give you a picture at the HRI level what's happening, but it's fairly well representative of how schools are distributed across Texas. Districts are distributed by type across Texas, although just eyeballing, we may be including more charter schools in this enrollment right now, proportionally, but we can look at that further. We know this is just this isn't complete enrollment, but and because it's aggregated, it doesn't tell individual HRIs much. But our plan is to look at this individually and be able to communicate that back in our reports. And I'll pause if there are any questions, and then Dr. Peskin was also going to go into more detail about our ongoing surveys and primary data collection that we've been planning. Okay.
I have a question.
Sure.
So I was reminded when I was talking about the TChat campuses that there are in Texas campuses or campuses in district that do have access to mental health care. And well, we are trying to reach those who don't. I'm just wondering, and I don't know if there is any way to identify those who do have access.
You read our minds. Yeah. Melissa and I were texting and saying we've got to meet because we are in a position where we can add that to our survey about that. Like we were saying, yeah, when we heard that come up too, it was it's an important point for us, and we can ask them in the surveys that we're conducting if you have other mental health services that you refer children to, so we can make sure, look at that. Is there over enrollment or under enrollment of these schools? So I really appreciate that question, and that it's a great question for us to add for sure.
Thanks.
Dr. Escamilla, see your hand?
I guess, just to complicate that point a little bit though, I just want to mention that a lot of times when we talk to schools, some of them do have arrangements with local mental health authorities for certain services, but even those ones who do have told us that there's gaps that TChat is filling for them.
Yeah.
So it's not a, either or. There are some schools that have no services and desperately need us, but even the ones that have some services have told us that we're really helping fill some gaps. So just wanted to make that point.
Yeah, I wonder if when we're developing these questions, if we could contact you, make sure that we're including the potential responses and probes following up on that, because and as an evaluator, definitely talking to stakeholders is important to make sure you're asking the right questions. Yeah. And it sounds like we could learn a lot from.
Oh, feel free. Yeah, we've definitely dealt with this with several schools, so feel free to reach out to me.
That would be great. Thanks. Melissa, do you want to continue it, and then we can do more questions?
Sure. So Nagla, if you could move to the next slide. And so this was just one additional slide. We just wanted to mention that we're going to be using the National School Lunch Program data to help us understand, sort of the diversity of the districts and where they fall on the percentage of students who are on free and reduced lunch. If you can go to the next slide. So, the above maps, as Laura mentioned, really give us a comprehensive overview of all of the clinics and districts that are participating in the CPAT and TChat initiatives. And so for the data collection activities that we're proposing, we really want to make sure that we are selecting clinics and school districts that represent across Texas that represent several diverse perspectives. So as we're selecting, because since we can't, talk to every clinic and every school district in Texas, we want to make sure that we get a good cross-section of perspectives. And so in terms of selecting our CPAN clinics to talk to, we've included clinics designated as federally qualified health centers. We're also making sure that we have a good distribution of clinics from counties classified as metro or non-metro. And then back to the SBI score that Laura talked about, we're trying to make sure that we have a good representation of clinics from counties with low, medium, or high SBI scores. And then as far as the TCHAT districts, we're trying to make sure that we have a good representation of districts that are urban or rural, and then districts that have high or low, a percentage free and reduced lunch eligibility. And so these are sort of the perspectives that we're trying to make sure that we capture, in the group of clinics and school districts that we select to conduct our data collection with. You can go to the next slide. So the first step, and I know we've talked about this before, but the first step in our evaluation plan has been to conduct these stakeholder interviews with informants from each HRI, and also a diverse sample of 10 CPAN clinics and 10 TCHAT school districts. And so the previous slide, we talked about how we selected our clinics and districts to ensure that we are representing a diverse perspective of clinics and districts. But just as a reminder, these interviews are used to create process maps that are really going to help us describe the current practices for participating HRIs, clinics, and districts. And earlier this month, we completed 24 interviews with all of the HRIs. And so we really appreciate, we got 100% participation from all of the HRIs, and are working on developing process maps for each HRI. And so now we're beginning to reach out to the HRIs to obtain main contacts for interviewing, interviewing people at the clinics and the school districts that are selected. And then following each interview, we'll create the detailed process maps, and then we'll follow up with stakeholders to make sure that we review their process map for accuracy. And then the next slide is just an example of one of the process maps, the CPAN process flow for one of the HRIs. And I know you can't read it, but it's just to give you a good idea of sort of the detail that we're trying to make sure that we capture from these process interviews, so that we really understand, step by step, how activities are moving from outreach, enrollment, training, follow-up. And this is going to really help us understand sort of what it's supposed to look like at the different HRIs and the different clinics, so that we can follow up later in our surveys to really assess fidelity and sort of how well, the different clinics and school districts are adhering to these models. So next slide. So we're also planning to distribute an implementation and outcome survey to our sample of clinic and school staff in late May, early June. And similar to our process mapping approach, we identified a diverse sample of clinics and school districts. And so our plan is that we're going to sample 500 clinic staff from about 100 clinics, and then about 250 school staff from districts as well. And the timeline, again, like I said, is late May through June 2021, and we'll be including outcomes such as implementation fidelity and level of implementation, determinants of implementation. So really, what are those factors, knowledge, attitudes, and skills that are associated with implementation? And so it's really important. Also, we wanted to make sure that we get a good representation of participants, who are implementing well, who may not be implementing as well, because we really want to understand, those factors that are really influencing program implementation. And we have a faculty member working with us who's an expert in implementation science, who's really helping us make sure that we are following, all of the latest methods related to implementation science, so that we can really understand those factors. And then also we'll be trying to understand implementation practices that increase equitable access. And then this next slide is just to tell you a little bit that we're also beginning our economic evaluation to assess the cost of mental health, the cost of these programs, and return on investment for implementing these programs. And so, as we've mentioned, this implementation analysis is really a very important part of understanding, how successful programs are. And so, our level of evaluation, we're going to be specifically looking at trying to document costs associated with these various levels of implementation. And we're using this time-driven, activity-based costing model to do this. And so really what we're doing now is we're trying to track personnel engaged in all of the different various implementation activities to really help guide the cost of implementation. And the process maps that we are developing are really serving as a guide to helping us understand all of the different activities that we need to try to assess costs for. And so we are planning to follow up with the HRIs to collect some additional time data to really try to understand, the extent of the amount of time that each of these different activities are taking. And so we'll be following up with HRIs in the future related to that. So, and then finally, I just wanted to acknowledge our team. We have a great team with a lot of different expertise. And I just wanted to acknowledge them. And then also, again, thank all of you for working with us and being so responsive to the evaluation. And we'll take any questions.
Very good. Any questions from the executive committee members? All right, looks like there's none. I see some thumbs up. Again, appreciate everyone's time and all the work that you're putting into this. So I need to call another audible related to the flow of the work from the agenda today. Dr. Williams, I hear you need to leave in a little bit, and so I'm going to pull you up and have you go, and we'll do number 5, and then we'll jump back to do the other items we've jumped over.
Thank you. I appreciate it. It's kind of a national presentation, and they just picked this day. So Edith, can you pull up the slides for Kosh? Hope everybody's having a good enough Friday. We were supposed to see rain today, and so far I haven't seen it, so I hope that continues. So I don't think that it'll take too long for us to go through the agenda right now. By now, it should seem pretty familiar to everybody. These are some Easter eggs that Madeline and I did during Easter, so I thought they were kind of cute. So there we go. So, well, too fast. That was too fast. Kosh updates. We are coming up on Cpan's 1-year anniversary. We are working with Dan and his team to sort of develop some educational and outreach materials to kind of highlight the things that we've done with Cpan over the course of the year. Obviously, all the individual HRIs are doing things as well at their local hub level, which is what we hope and expect. But we are coming up, Child Mental Health Awareness Week was when we launched last year, May 2020. And so we're trying to come up with some activities and programming, and then just nice informational pieces to give people for the 1-year anniversary. Also, when it comes to social media, Edith has definitely been helping make sure that our social media presence, as far as talking about the things that we're doing across the consortium, for both actually primarily Cpan, but also whenever we do presentations related to TChat as well. So Edith, did you want to say anything specific related to some of the insights for social media?
Yeah, sure. So just a quick update. Our LinkedIn page is currently being revamped. And then our Instagram page just launched last month. And in Facebook, we have the numbers that we have up on the screen now, which has had a good presence, 4,000 or so people reached. DMEs have been posted across the state, 31 events. And then we've also had 198 response to attend these events. So it looks like we're growing our presence a lot on social media, and definitely looking forward to seeing it grow more with the 2 additional pages that we have. And then let's see, here are our pages here. If you have not followed us yet, please do so. We post updates on Cpan on every single page, and also events that are happening across the state.
So we coordinate with Dan when it comes to marketing, because again, what we want to do with our Facebook page and Instagram and LinkedIn is to provide providers across the state of Texas information about when we're doing different activities, also just important or salient facts related to children's mental health. And so if you go to our Facebook page right now, if you haven't, I'm actually encouraging you to stop listening to me and go look at Facebook page. You will see all the different events from across all the different hubs, all the great work that all the 12 hubs are doing. And so it's really hopefully a good way for us to have a wide audience. So the more that we kind of link in, for lack of a better word, and connect with other PCPs, other practitioners, get the word out about all our events and our activities. So just really happy to have that sort of getting more robust. Next slide. Drs. Vo and Pliska, did you want to share a little bit about where things stand when it comes to data governance?
Sure. There's 2 main ongoing activities that we're engaged in data governance right now. The first being, developing our data definitions for both Cpan and TChat, so that way we can guide TRAIT to build a mechanism to capture the data in the dashboards. The second one is really outlining the data landscape that we have, which means essentially developing a data map to determine the data sources. And this work is really being done by Dr. Lopez and her team. I think I'm going to turn it over to David Lynch, because Dr. Lopez has to step off, and he's going to show just some examples of both the data definitions and the data landscape that we're doing. And also a part of this effort actually is determining the data steward piece, which includes hiring a data manager in the cost to collect, clean, and manage data towards a data core that the internal, external evals and other entities can access. So with that, I'll turn it over to David Lynch. Dr. Pliska, did you have anything to add to that or not?
Yeah, one of the things we're engaged in, the interaction between the data governance and the data work group committee. So to kind of look at it from a research perspective, typically in a research study, you gather what's called your source material. I mean, your interviews, your rating scales, your core data that's gathered by the investigators. Those generally get entered into the database, which becomes the official repository of the data. And ultimately, that database is locked, and then the statisticians go to work to analyze it, and all of our conclusions then draw from that single database. Of course, right now in the consortium, we have multiple sources. TRAIT is a major one for Cpan, and now ultimately for TRAIT, for TChat. But then in the other programs, we've got all kinds of data that needs to be collected and stored somewhere. We had rather extended discussions with Molly as to whether their role as the internal evaluation team, will they become the stewards and the place, and will they maintain the database? And that's not a role we actually originally proposed for them, and we don't know that we've resourced them appropriately. Is Kosh going to become the repository and the steward of the data? Well, I don't think we were explicit about that. Clearly, to take just and we'll get into CPE later, just a small example, I found myself in the situation of emailing the site saying, send me your data, and then I forward it on to Luann, and that is not an optimal situation. First of all, you're dependent on me to be the data manager for CPE, but more important, we need to have a formal process for doing that. And the same is true for all of our projects that are not specifically, the source for the data is not specifically in TRAIT. So we really want to kind of move forward on that fairly quickly.
I was mistaken. Dr. Lopez is actually still on, so I'll let her take over and show sample of some stuff that we've been working on and her group has contributed to. So Molly?
Sure. Although it would have been fine for David to do it as well. I'm going to have to, I think you, so yeah, thank you. So just to give you guys a little sense of a visual, and it's too much to read, I totally get that, and small, but really what we're trying to do is line out kind of what the different data sources are, and you'll see those kind of in these rectangular boxes and sort of who's holding that data at present. And then in the green boxes below are the variable names of the different variables that are laid out. This happens to be Cpan because that's where we have the most kind of well laid out variables and kind of sources at present. So that's a good place for us to start. It's also one of the more complex ones. And then we took a stab at sort of laying out some of our metrics, which are identified here in the circles, in the red circles. And then starting to lay out sort of how those are being defined by linking them to the specific variable names that are pulled in to create some of this. And I think it's given us a chance to kind of visualize, make sure that we're all in agreement about kind of what the data sources are and what the variables are that are being used to calculate some of these measures, and also raised some particular gaps that we want to make sure that we better define or fulfill. Like you'll notice up here, we're still working on how do we make sure we all are in agreement about the denominator of the number of providers within a region that lets us say how many of our PCPs are enrolled versus the overall population. So we're still laying out some information about how we're going to all determine that denominator. So it's just a way to kind of help us understand the scope of what we've got, as well as all come to some agreement about how each of the measures are identified. I'll stop there.
Thank you. That's a lot of work. We've added some additional meetings to organize the conversations for the data governance. So we actually have a subcommittee that now reports up the Data Governance Council, because again, as Drs. Pliskova and Lopez have noted, there's several sort of things that need to be kind of done in parallel, but then also potentially sequentially. So we want to try to move on those as rapidly as we can.
And it's a big deal. I want to kind of put that out to the executive committee because we've kind of left this piece not fully defined, and it's really critical. And in particular, the data guardian, the data, is that going to be within Kosh? Is it going to be with Molly and her team, in which case she may need more resources, or is it going to be in some other entity? And it's going to need to be staffed a little bit more. Maybe one data manager can be the one that's reaching out to HRI number 4, you didn't turn in your Cpan FTE, your CPW FTEs, HRA number 3, I got the spreadsheet, but this wasn't filled in right. That's the kind of nitty gritty that data management is going to involve. Just like when I do a research study, a drug study, clinical trial, I see the patient, I fill the stuff up, then I get queries from the company that say, you didn't check this box, or this is inconsistent with that. So their data, when it's analyzed, is clean. We've got to kind of be in the same mode.
Yeah, I want to underscore what Dr. Pliska is saying. I think when we first started out a couple of years ago, we had some very simple metrics that we were supposed to report back up to the state on both Cpan and TChat and all the other initiatives. But what we started to realize was the data itself is massive, and to manage that, we do need to have some kind of resources geared towards that, and certain groups to do that with. And so, what we did not realize how large the data set is going to be, or is right now, and growing. And so, I think as we dive into this, we're really seeing the scope of how much work it's going to take.
Agreed. Thank you. So now we'll go ahead and move on. We are working actually on the continuation of developing the manual. So with the goal that Edith has, and well, myself and Edith, is that we're going to have a manual both for Cpan and TChat. We're working on Cpan first. And within that manual, it'll have hyperlinks to the various sort of pieces that we need to make sure that everybody is following and doing consistently, sort of back to that external evaluations team concept about implementation to make sure that we are implementing Cpan across the state in a uniform way. And then we also are, every team is doing a ton of CME in a variety of ways. And so that I'm sort of saying, thank you. And please, again, go look at Facebook. You can see up to date all the activities that we've been doing. But we are working also on a sort of statewide echo project that would have each of the 12 hubs for providing an echo to local primary care physicians within their region. So we're having our first planning meeting for that project in April. Next. So Edith is going to transition over to the dashboard for the data for Cpan. And what we'd like to call your attention to again is that top row. Edith is going to hover over things so you can see this is the number of providers that we have currently within the Cpan network of over 4,000. As you can see, within 746 clinics. To date, since inception of May of 2020, we have had over 1,500 completed consults with approximately 1,400 patients served. And as you can see here, our teams are doing an excellent job with calling back within that 30 minutes. And so we're seeing a median response time is actually 11 minutes. So that primary care physician wanting to speak to a psychiatrist in particular across the Texas, we're doing a great job there. As you can see here, our clinic enrollment, we continue to have more and more enrollment month to month, which is hopefully obviously what we expect. And as the external evaluation team, I think mentioned a few minutes ago, you can see here the breakdown with the types of clinics and providers. And you can see here, pediatrics still is sort of the majority, then followed by family medicine and then an integrated care model. So again, we're seeing really very cleanly here the types of providers who are enrolling into our Cpan networks. Moving down, I want to put our highlight over to the way left with the consult activity. Survey says in the month of March, we had 479 new consults to Cpan in the month of March. So this is fantastic. All the teams across Texas, I just want to give a shout out with all the great work that you're doing. We're very excited to see this number. And so I just want to, again, highlight that month to month, we continue to see growth in the number of consultations that are being requested for Cpan across the state. Again, when you look here at the next one, the clinic staff engagement, you will see again that we have about 40% of providers are calling again. So this to me also points to the usefulness of Cpan is that once a provider calls once, they're definitely a good chance they're going to call us again because they had such a good service. And they're finding us to be helpful to them. And here, when you look at the clinic staff roles, obviously the overwhelming percentage of people calling in are physicians, but we also do have nurse practitioners, physician assistants, counselors, other people, because remember, Cpan is not just that psychiatric consult. Our teams also help with resource referral management, as well as brief behavioral interventions. So maybe they want to sort of learn how to help a young person and they don't need to speak to psychiatrists particularly. So just really excellent work across the board. And moving down to the last one that I want to show just right here, purpose of content. Again, the overwhelming majority of the time they're calling about a specific patient. They are often asking for help with referrals. About half of the time they are asking medication related questions, and almost 40% of the time they're asking directly to speak with a psychiatrist to get help. We've seen a very small uptick in this area around about an emergency. We're actually going to be talking about that today at 4 o'clock at our state Cpan meeting to talk about making sure we're actually doing that in a uniform way across the state. And then when you see the types of referrals that we are doing, again, we're most of the time referring to a local therapist, 27% of the time to a local psychiatrist, and then a higher level of care. Actually, when you start talking about the data across the board and what we might look at over time, I think it's interesting that we'll be able to start to see in more detail what kinds of referrals are we making and what's that look like, and do they change over time as well. So again, a lot of excellent work has happened in this last month. And so I just want to congratulate all the teams. Thank you. Next slide. Back and forth. Next slide. So for TChat, next slide. We now have all of the teams are now accepting referrals. Again, this has been to start a clinic, a system of care for a service within a school is no small feat. And so I also just want to commend all the 12 HRIs for being able to get to this point. There's a lot of just moving parts that have to occur because we're doing things with schools. And there's just many elements, particularly related to legal training to make sure that everything gets set up appropriately. So I think it is phenomenal that all teams have been able to work through the various challenges that have occurred and always occur when you're doing something new to have the ability to be accepting referrals. We are working with the build out, the expectations around the rollout of full utilization of trait. We're actually be having that conversation with the TChat teams on Monday, but we will be able to have a much richer data set in the coming months as we transition away from sort of limited data sets that we have to the full utilization that we are going to be doing with trait. And so we are also talking about consideration of what types of programming are we going to do during the summer months. All the HRIs are going to still have a process in place for youth to be referred. We also know that with school out and kids being out of school, that there's a possibility that we'll have less referrals. So most of the teams are working hard on coming up with materials for education to staff at schools, to families, and we actually have a group is convening. The Dell team wanted to help spearhead it. We're very thankful for them to do that, sort of talk about any kind of additional activities that we can do during the summer months to kind of keep our presence in the schools and be helpful in the ways that the schools will need us. And then in a few minutes, we'll have Dr. Storch and Andrew, I'm blanking on your last name, will present about step care updates. Next slide. Just want a top line before I actually look at the March data is that since in April, Edith sort of pulled this for me the other day. Since the beginning of the year, we've had 1,500 referrals to TChat. Over 600 students have actually received a TChat service in over 510 schools across Texas. So again, that's sort of just a high level number related to the last sort of 8 months of school. But in the month of March, 182 schools requested and received a service through TChat. There were 645 referrals. Obviously, depending on when the referral came in, you can't always get the patient in right after that referral. So that's why we don't necessarily tag it directly right to that appointment. But what you can see here is 286 of those 645 referrals were served actually in the month of March. Next. Again, I think I'm just kind of saying this in a slightly different way, and you can see this over time between January, February, and March. So not to be unexpected for those of us who do work in child mental health, the spike for when kids are most needing services are in the October, November timeframe and the sort of February, March timeframe. To me, it sort of corresponds when sort of 6 weeks grades go out for school children. But certainly we saw that bump up in March. Next. Again, it's trending to be kind of similar from month to month. This one here, the majority of, backwards, or either way, that's fine. The majority of the types of services that young people are getting are psychotherapy by itself, 12% psychiatry, a combined percent of both maybe seeing a psychiatrist and a therapist. Next. And then again, you can just see this month to month, and it's mostly similar from month to month. When we look at race and ethnicity, I don't think we also are not seeing it necessarily any big changes here. We are trying to get the HRs to make sure that they provide this information to us, and that has improved as well. And again, there's not any real changes when it relates to gender. And again, the same thing. That's why we're not showing you a comparison from month to month. There's not really any huge changes when it relates to demographics with age. So now I'm going to turn it over to Dr. Storch and Andrew, and I'm actually possibly going to pause Edith, so the next couple of slides that relate to WellNeti after this, if you could go ahead and take that, that would be great.
Sure.
Thank you.
Well, thank you very much. Edith, if you can step to the next slide, please. What we want to talk a little bit about is really progress to date with the pilot trial of step care within TChat. Next one. And then we can skip to that one. Yeah. So our goals are really twofold. One of these goals is really to pilot a step care model of cognitive behavioral therapy within TChat, with the idea that there may be a number of kids who require additional services beyond TChat. And then likewise, how do we coordinate service delivery of evidence-based intervention across multiple TChat sites? Next slide. So we ended up thinking about an initial treatment approach. So as everyone on this call is very experienced with, there are different behavioral therapy protocols that are evidence-based and usually developed through NIH funds and evaluated in a similar fashion. What we and some others have done is we kind of took this as our infrastructure and format for TChat. Where we've had some guidance and structure in terms of providing this type of approach in those first several sessions. Now, one of the reasons why we wanted to embrace the unified protocol in this regard is this transdiagnostic focus and ability to be applicable to kids with a wide range of internalizing problems. So this isn't a treatment that is appropriate for children who are experiencing post-traumatic stress symptoms or children who are disruptive or have ADHD, but really kind of capturing a broad swath of kids with anxiety and depression as some of their core problems. Now, within a step care approach, we were providing usual care, TChat, and then with a measurement-based model of care, evaluating the need to step up to an additional dose of treatment within a 3-month interval of time for a total of 12 sessions. We wanted to focus on widely accessible, quick, and well-validated measures, including youth top problems, PHQ, and the SCARED. Next slide, please. And so our model sort of looks like this. Now, one of the exciting parts of this project is we had incredible feedback from a number of members on this call and several not on this call in terms of how to conceptualize this approach, measurement, the so on steps. But it sort of details, this graphic details what we're doing. Again, initial intake followed by treatment. And then those that require more treatment, kind of progressing through that step 2 versus case management referral to community resources as appropriate. Next one, please. So progress to date has been great. So first off, we've had incredible collaboration with a number of HRIs. We remain very open and eager to embrace others, should there be interest. Next slide. And we launched about 2 months ago. And that launch initially consisted of training within the unified protocol in a didactic web-based format, reading manuals, of course. And then we've had ongoing consultation calls where really our goal is to provide high fidelity evidence-based psychotherapy. We had kids start coming in March after about, again, that month of kind of onboarding. Next slide. And then treatment has progressed. So very similar to some of the past slides, we're seeing teenagers as sort of the median of these 40 kids that have been enrolled since the beginning of March. And then we're seeing, for whatever reasons, more females than males, which may be explained by our focus on depression and anxiety. Next slide. Now, this is still pretty this is still pretty early within process. So what we would anticipate is, about 3 months in, we would have a full dose or full kind of approximation of how that initial cohort of kids were doing in terms of stepping up. So at this point, we've only had 3 kids make it through that initial kind of four session protocol. All 3 kids have stepped up. So you can't make too much of that. But I think those of us sort of in the trenches are seeing that a lot of these kids require more help than we're able to provide. But we'll see if that trajectory remains. Next slide, please. If we try to quantify severity, we're seeing that this is a pretty depressed group of individuals. In our next slide, speaks to the level of anxiety, where also high rates of child-reported anxiety, and a little bit surprisingly, the parents aren't corresponding as well as we might anticipate with their children's anxiety. Next slide, please. So we've been incredibly happy with progress to date. And in terms of just the onboarding, the fact that in a relatively short period of time, we've been able to take over a dozen clinicians, have them well-versed in a treatment protocol, in which most hadn't been doing this, start providing high fidelity intervention according to this treatment protocol, and implementing measurement to really understand kind of what's happening, and then make clinical decisions based on that. I think the clinicians at least are happy with this, which they at least tell us that. And I think the questions that remain are severalfold. One is really this idea of, what's going to happen? Are we going to end up stepping up most of our kids? Really for one, or will it kind of factor out in a more balanced fashion? In some of our work with PTSD, what we ended up seeing were about 40% of kids did not require a step up to additional services, but about 2/3 in fact did. Like everyone, the connection to resources remains a challenge, and so that's something that this project, broadly speaking, the consortium will continue to build out. And then we want to be able to track these important metrics. So to what extent do we see reductions in depression and anxiety at kind of that early point after 4 sessions? And then how much better do kids get if we provide some additional support and treatment? Likewise, are we seeing most kids step up to that, which would be an important indicator for us. A second next step, as we heard about earlier, is how do we streamline and really fully integrate the measurement, measurement-based approach, utilizing trait to its fullest extent, which I think we can continue to do. And then a third is thinking about who are the other kids that are missing out. So I mentioned that one of my colleagues and I are finishing an NIMH-funded trial where we used a step care approach in children who have been traumatized. Another approach is thinking about disruptive behavior. And so thinking of how we can kind of assess what are the psychotherapeutic needs of individuals, and then how do we provide a dose-based approach for their treatment. The last thing I'll say before the next slide is, Dr. Andrew Guzik's been incredible and really, spearheading a lot of this and working tirelessly in this effort, as well as the therapist as part of the participating HRIs who have just been outstanding in their clinical care, and sometimes doing some of the less fun bureaucratic things that allow us to answer those questions of, how well is this working and how relevant and important might this be? All right, I think next slide, which is whatever's next. Yeah. All right, any questions or comments?
All right. And the last update that COSH has is on WellNeti, which is our resource platform. We have a final review for it on May 5th and plan to go live May 17th with that. And I believe that is all.
All right, very good. A lot of progress taking place in building all these programs. Any questions for Edith or for Eric? All right, well, hearing none, thank you all. And we go back a little bit on the agenda and let's go, Dr. Martin, let's go to you and the update and the presentation of the work that you're doing in El Paso.
Great, thank you. Okay, I'm gonna share my screen. All right. Can you all see just one slide, or do you see?
We see both the slide, this slide and the next slide.
And the next slide. Okay, I know there's a way to change that.
You turn off your, yeah.
There it goes.
All right.
Okay, all right, did it right. Okay. This is, I'm Sarah Martin from Texas Tech El Paso. I'm a child psychiatrist. And the first slide we have here is about our kind of our overarching philosophy that we are following. And we got this, we adapted this from the National Cultural Linguistic Standards of Care in the Office of Minority Health. Ours is there are probably, varies from study to study, but approximately at least 50% of people in El Paso prefer to speak Spanish. Many are bilingual, but we definitely are trying to improve our services by taking that into account. And we focus on trying to have multilingual staff, residents, fellows, and strong ties to the community. So you'll see that kind of reflected throughout everything we do. This is our community engagement framework. It is pretty complicated, but it's basically is saying that we are trying to meet with everybody in our community that we can, that have anything to do with children, mental health, and a lot of times both, but not necessarily. And here is one of our favorite photos, because this was the first presentation that we were invited to do. In the center, this man in the center is one of our T-chat therapists. This is our first presentation we're invited to do in person, even though COVID was going strong. And this is a family medicine clinic at Texas Tech. And it was actually a Cpan. Another reason I like this photo is because it was a Cpan presentation in terms of it was to a primary care clinic, but all of our therapists have been very involved in all of the different projects. This is our area. And one thing that's interesting about our area is that to drive from El Paso, where we are, it takes 7 hours and 15 minutes to drive to Eagle Pass, which is the southernmost town in our region, in our service coverage area. Below here, the red dots mean that everyone signed up with Texas Tech El Paso. So we made it red for our colors. Yellow means it's in the works. They have agreed to sign, and we don't have the paperwork yet. And one thing we've decided to do with these districts, because sometimes it's a long process, we start educating, offering education, training about T-chat, that sort of thing, as soon as we see any interest. Here, the orange line is how many schools we had planned in our original PDV to enroll, which is 36. And this is how many we've been able to enroll. And these are not even including the ones that have already said they're going to enroll and they haven't. So we've been very happy about that, because it looks, we've exceeded our own expectations. So we're very happy about that. And in our original plan, we were going to start with high schools and go out, expand from there, but everything was so slow in the beginning of COVID. We immediately expanded from pre-K all the way to, like we say, high school. But of course, we include those special education students that stay in the high school until age 22. This is our referrals by month. And you can see here in February, referrals went down and the not seen patients went down, or the treated, sorry. Not the referrals, but the not seen patients went up. This was, of course, the month we had that freeze. We in El Paso did not suffer from it too much, but many of our patients we see through TChat are in Del Rio. They're a very, very active partner with us in many ways, and they're even helping us with Cpan. They're going to host a Cpan event for us at the school district, so we're so happy about that. These are some of the things that we've been doing to get people on board and to meet the needs of the schools. We've done initial trainings, mental health and wellness education sessions. We had a lot of people requesting sessions about grief. That's probably been the number one. We've had so many, everybody's lost so many people due to COVID. So we've been trying to meet that need through online training, wellness support type sessions for teachers. And also we're getting a lot of requests for parent groups now. We've been meeting with the individual TChats, and these are just the numbers of meetings we've had. And we started to have ISD-wide parent information sessions. Usually it's one school kind of takes the lead and they set it up. And so we've had 2, but we have just signed up to do a series of 10 for one of the local school districts. And then also the ESCs. We've done 2 ESC-wide trainings. Our school districts that we are offering service to are in 3 different ESCs, and they've been great partners. Let's see. Let's skip one. No. Okay. These are the places we want to go in the future. So I don't know if this is helpful to people, but this is what we are thinking about. Rural expansion. You could see on our map that we have Del Rio and we have El Paso, although not every school in El Paso County, but most of the school districts in El Paso County. But there's a lot of very small school districts in between that we're talking with. And so hopefully more of them will be on board in the future. With mental health screening, this is our big summer plan, is to offer mental health screening to all the summer schools, students. I'm making them patients. They're not patients, they're students. What we want to do is, we know that this has been a hard year for students, and we know that kids are having trouble, and we felt that there would be a high concentration of kids that needed extra help in summer school. And so that is what we are planning to offer. And all the schools we've talked to about it so far are interested. We're going to line it up completely with TChat in terms of we're going to do the same screenings we do for TChat, ADHD, anxiety, depression. And then if they are positive, then we'll have the consent signed in a way that then they would receive an evaluation from a therapist. Community engagement. We're going to start a story time. We'll see if anyone likes that. Mental health awareness. We already offer this, but we want to expand this, especially in terms of parents. And we would love to have a program where LPCAs can get hours. That is one of the big shortages in our community and probably everywhere, LPCs that will see children. And so if we could have a program where you rotate with us and you get your hours and provide service to us, it would be kind of the same idea as a residency for psychiatry, but just for LPCAs. That's one of my dreams. We'll see how it goes. I'll let you know. Staffing, we thought you guys might be interested in who we have hired, who we would like to hire, any kind of changes we've made over these last 2 years. The team we have already is probably very similar to other people's teams. And in the beginning, we did not hire a medical assistant, but the scheduling and all that for all the different school districts, it was very complicated. And so everything's running much, much, much more smoothly now that we have her. We do have the residents and fellows rotating on our service, and we have supervisors for the child psychiatry attending courses supervising that. And that has worked out really well for the most part. One thing that we are interested in is having a clinical director working directly with the therapists and the psychiatrists to make sure things that are moving smoothly. Someone who has run a clinic before. So that's one thing we are interested. And then all these LPC interns, MSW interns, LSSP, that's licensed school psychology, license. I'm probably saying it wrong, but basically they're school psychologists. That's what their official title would be. So they have internships, and the Texas Tech Lubbock has a program, but they have an intern that's stationed here in El Paso, and they want to rotate with us. So maybe we can set that up in the future too. Cpan. Okay, Cpan, this is one of the things that we have developed. It's a photo of it, and I can send people the actual electronic file if they want to print these out. I'll just change Texas Tech to whatever your school is. The original idea came from Dr. Pliska, one of the pediatricians that is in our Cpan and actually here also at Texas Tech El Paso. Had seen a flyer that Dr. Pliska had put together for a Cpan-like project, but several years ago. And it was a trifold, full page, and then the trifold brochure with how to start and titrate first-line medication, psychiatric medications for children. And so this was a request from a pediatrician in our university. First, we did this, we kept it just one card, front and back, and then she wanted more and more. So we added it up, and it's 3 cards and it was her idea also to attach it to the badge holder. So pediatricians, family medicine, NPs, PAs, they can add this right to the back of where the codes and stuff are. So anybody wants this file, just email me, we'll send it out. And we just now are starting to go in person and hand these out. So we'll let you know if people like them. Hopefully they will. And thanks to Dr. Pliska. Quick facts, continuing medical education. Okay, this has been one of our hugely successful things that I wouldn't have imagined in a million years that so many people would attend, and I've been so happy. So so we have a grand rounds called Child Psychiatry for the primary care provider. And our first one was, I think depression and anxiety was first. 17 people attended. And we had a half-day symposium just a couple of weeks ago, 258 people attended. So we've been so happy. I should have made a graph of that one because it would have looked impressive. We've been very happy. Dr. Thompson told me after the first one, or after a few weeks after we started, I said, well, we get about 50 people. And he's like, oh, okay, well, your goal needs to be 100. And I was like, oh my gosh, that sounds scary. But you know what? We get 100 all the time now. So we do it twice a month. These are some of the topics. We're always looking for guest speakers. So any of you all in the audience, if you would like to present on any type of topic related to children, please let me know. We'd love to have you. We did a half-day symposium, and these numbers here, not only did this many people attend, these are the amount of people who actually stayed long enough to get the full amount of credit. And this one here, the mental health and substance use symposium, it was focused on the border area, and it was focused on what's going on in our community new because of COVID. And 258 people stayed long enough to get their 4 hours of credit. And these were the 4 presenters we had: human trafficking, mental health during COVID, regional resource updates was a panel, wellness and mindfulness. That was an actual mindfulness session. One of our psychologists doing like a 5-minute exercise in mindfulness. And people loved it. And we did that right in the beginning. Right in the middle of it, because a lot of this stuff are the very, very heavy topics. So we put that right in the middle. And then the panel, we invited people from all over El Paso County to discuss what has changed in their organizations and what they are offering. And I've been here so many years, and I learned so much, even at this thing that I set up myself, and I thought I already knew it all. I do not know it all, and I learn something new every day, but I learned a lot about what is going on in our community. And then we had breakout rooms at the end, And the breakout rooms were so successful that they got cut off because of the end of the conference. And so we had to quick and do our Zoom magic to make them open up again so people could continue talking. So we were so happy. So I would really recommend having this with your service areas. It was very enjoyable. It is a lot of work, but it was enjoyable. These are just some of the guest lectures that we've done for different organizations. We've done 9 for professional organizations. The National Association of Psychiatric Nurse Practitioners was especially interested. And so I met with their state team, with their El Paso team. And the El Paso meeting was interesting because there were about 8 people that joined that meeting. And no, this was a Texas meeting. There's about 8 people that was the Texas officers. They had joined the meeting, and one of them, she had rotated with me when I was doing a Cpan type service over at Fort Bliss. And then another one was the MP that works with my daughter's pediatrician. So out of the 8, I had already come across 2 of them. So all these projects are leading into all the other projects, which is really, really fun. And then we did a YWCA panel about COVID. And this was a Women in Medicine and Science series that we do. And so it was the chair of pediatrics and myself talking about COVID. And generally, those are for the general public, like members of the YWCA who use like their babysitting services or their GEM services. But once it went virtual, a lot of doctors go to these. So there was tons of pediatricians in the audience. So it actually turned out great. And AHEC, I would really recommend working with your local AHEC. Ours is called Desert Mountain Area Health Education. I'm forgetting what the C is, but it's a grant, and I think it's in all areas of Texas. And so they helped us put together this half-day symposium that was so highly attended. Lessons learned. Okay, I always talk about the good stuff first. Lessons learned, it's good to learn lessons. Some of them were a little bit on the hard side. Okay, I'll say not effective. We haven't gotten that many people through cold calling, just having lists of doctors and trying to call them. Faxing, we got a couple people. Letter writing, a couple people, but mostly it's been word of mouth, being a guest speaker, and live events. I put live events here. We've definitely had the most contact with the public through the live events. And there's so much we've tried to do. We're doing modules where you log on and you do all the activities and then you get your CME credit at the end. Those are very, very, very time consuming. Whereas having a live event, it's much simpler to actually produce that. So I would recommend focusing on that, but we're already doing the other. So we're going to do both, but the other one was more effective. And people really like the Med card so far, the kind of the cheat sheet. So those are the things probably that have worked the best for us. So we've been going through a list of all the people that have been coming to our live events. And these are the type of people that come, not just PCPs. PCPs are a portion, but CPS workers, foster parents, LPCs, LCSWs, group home staff. There's an agency in, I think it's in Harlingen, but it's definitely in Dr. Escamilla's section of Texas, and it's called Healing Hands. And they come every single week. Inpatient staff, I'm talking about psychiatry, of course, mostly. Lots of nurses, Texas Tech, our own faculty are coming a lot to these. So it's helped with our relationship with pediatrics immensely. We've had judges, all the JPB, all the Juvenile Justice Center faculty, staff, and their judges are even coming to these. The Texas House and Senate staff from our region also attend these. HHS employees, I think it's HHSC, I like to see. They've been coming, even people that are high up that are in charge of some project that is for the whole of Texas. And then a lot of people in private practice, tons and tons of people that are a nonprofit, like the LMHAs or local community health, and then FQHC staff. So it has been a great community builder just even separate from Cpan. So that's been great. And this is who we have for Cpan. Now we have, these are not FTEs on this slide or the previous slide. These are the actual people that work on. So when it says medical director, it's probably me, but I'm on a couple of different projects. And then our CMA helps us with medical stuff here too on Cpan. And we always get departmental support, and we have a project manager, an administrator. Okay, this here is a photo of our very first post-COVID, or during COVID really, trip that we went on. And that's me. This is Paulina Rodriguez. She is the program coordinator for Cpan. This is a Cpan trip. Adrienne Harrell, she is our program manager for all of the SB11 type programs here at Texas Tech El Paso. And Bethany Shrewsbury is our new LPC, one of the LPCs that helps us with the referrals and the outreach. And this is, I'm not advertising for Blue Cross, but Texas Tech El Paso got a grant for this van so that people could provide rural health education or rural health services. So we drove this van to Alpine and Marfa, and we were received so well. They gave us lunch. They introduced us to every single doctor and nurse practitioner and PA in both of those towns. It was really great. It was really great. And it turns out it was Dr. Adrian Billings. He is a community faculty at Texas Tech Lubbock. It turns out he knew, my husband used to work for his uncle. So, you know, it's a small world. Workforce expansion and the fellowship. These programs from the very beginning went so well. We were able to get our 2 fellows, and we do not fill every year. So we're very, very grateful for that. We've had them we've had the fellows as presenters in our Grand Round series, and they have done a great job. And now they're seen as leaders in the community and the topic they presented, and it's opened up doors for them. We have greatly expanded our psychotherapy training because now that we are so fully funded in terms of education, we were able to use, and now everybody has online resources. So, you know, we can send them to McLean for their psychotherapy training in, you know, all these different psychotherapies that I am not, neither me or any of the other faculty here are specialists in. And so they've gotten to really expand their psychotherapy training. And then of course, a technology upgrade. CPWE, our goal was to work with these 3 agencies. And oh my gosh, this one, Child Guidance Center, we started in April of 2020. So, I mean, we started right away, but all 3 of these are now up and running. And it's been a great experience for it's been a great learning experience for the residents and the faculty, because faculty are, you know, they usually don't, if they're faculty with us, they haven't worked sometimes in places like an LMHA or Oliviani, which is a substance use treatment center that serves people who really have no insurance and are not able to spend money on healthcare. So it's been really important experiences for all of us. And then we also we actually are switching around our staffing so that we're going to have a director of education and research who will help us implement all of the educational and scholarly activity ideas that faculty and psychiatry departments probably everywhere always have and never have quite enough time to do. So we're excited about that. Research. I already told you my story about my patient who's doing so well. Because all the depth of the suicidal ideation was picked up during the research. I have learned so much, very steep learning curve. I wish I had more research analysts on my team so we could do more recruiting and see more patients. I didn't really understand in the beginning how much time it would take to complete each patient assessment. And we have engaged so another way that each of the 5 projects are feeding into each other. All the people who are doing the CPWE program also want to be involved in the research. Since we know them so well now, it's almost any help we ask for, they say yes and then go and figure it out. So it's really been a great experience. So that's my last slide. I have a great team. We've hired so many wonderful people that have helped me, not just with this presentation, but with everything we've done. One of the big outcomes that I hadn't really thought about ahead of time was that all the projects do feed into each other. And it has brought us so much closer to all the other medical and behavioral health community members of the community. And we have, every time I go to a meeting with one of them, with another agency, or even this meeting, I always now have like a notebook of my new ideas that I come up with when I meet with everyone. So thanks to everybody that's helped me with this. And we are excited to keep on moving forward. This photo here, Dr. Thompson and Dr. Longhurst, she's our psychologist, and they had a separate grant, separate from SB 11, to have a wellness tent outside of, this is a parking lot that's right across from Texas Tech Clinics and library right here. This is the Children's Hospital. Right behind is the county hospital, and right next door is the state psychiatric hospital. And so they could go in there and have a meditation or a snack or water. No drinks, just water. So it was, it's been a great project. So thanks to the Meadows for that. I think that's all. Thanks for listening.
That's a great story. And thank you, Dr. Martin. And I think part of the purpose is to see that to share, you know, how you are overcoming a lot of those challenges. You talked about the distances that you have to travel, you know, and rethinking how do you move all these programs together, and you know, the synergy there that you're developing, the development of the research project. Again, everything kind of coming together, and you know, it's a really great story. And so thought it'd be good to share that, because many of you have some of the same challenges, and I'm happy to just kind of open it up and let people ask you, you know, their own questions related to the particulars and how it can be applied to their area. Any questions from the executive committee?
Dr. Martin, this is Dr. Bryant, and you are an absolute inspiration, I want you to know, and absolutely an excellent role model for all of us. And I would be very interested in knowing about the McLean psychotherapy training. We're still waiting to find out if our child fellowship has been accredited, but if we do get it accredited, I'm very curious to know about those resources. So I'd love to have you share those with me. But I love the way you've brought everything together, especially in a place that is so, where your sites are so geographically separated. That is such an achievement. It really is. So thank you for that.
Thanks so much. And I'll give you a list of all the places that our fellows and residents have done some extra psychotherapy training. I'll send it to you. Thanks.
Well, Sarah, I just want to congratulate you. You know, this was a big lift. And being at a place that wasn't used to doing these huge projects, you've jumped into it, and it's an inspiring story for all of us. So, you know, congratulations.
Oh, thank you so much. Yes, the research of all these projects, that was probably the one that was the most intimidating for me personally. Luckily, we have Dr. Thompson, who has more experience, and he's been great. And then Dr. Gadad at our institution has been real helpful too. And but thanks for including us, and thanks to Dr. Trivedi for being patient with me. And we're up there with the you big guys now. So I'm happy. I'm very happy.
Dr. Trivedi, I see your hand.
So I still, congratulations. I just have to second what Charlie said, and you are one of the big guys, so don't worry. But my suggestion to you is, I think your community engagement process that you went through, I think is fantastic, because it captures rural as well as Hispanic population community outreach. I would suggest you write that up. I don't think that is often done because it is a much multi-dimensional and multimodal real community engagement. So think about having that written up, because that is something that other rural areas and more than rural, diverse region can use, because I think going 7 hours away to do the community engagement is worthwhile. So think about putting that as a report somewhere.
Oh, thank you so much. I had not thought about that at all, so.
No, I agree. It's a great story, and the coupling of teleeducation, these large conferences, coupled with going out into the community in the van, coupled with the working with the schools in a rural and knowing your area. It's not just rural; it's in many ways a frontier area of the state, and so the different approach, and you have to do it differently than Dr. Trivedi can in downtown Dallas. And again, that's still general principles of engaging the community, but you have to know your community and how that works and do it differently. And so I think that's the power of having all you guys around the table right now sharing ideas. Any other comments? Dr. Thompson, it looks like you're talking and you turned on your camera, but
I'm sorry. I just want to echo everything that everyone's saying, and congratulations to Sarah. You just can't imagine the enthusiasm that she has in building an organization that really was zero. But I mean, I think the lessons that I'm kind of getting from all of this is really to move the academic experience into the community, and rather than have them be two silos, really they become one. And so I think when Sarah talks about these different organizations, what she's really talking about is transforming the academic experience and taking away all these different barriers. And so it's been a pleasure to watch.
No, I think that's absolutely correct. And for far too long, the mental health community, it seems to me, has been very siloed. And now we have folks like you that are in academia that know what the community is like, and the folks from the local mental health authorities that are feeling more comfortable working with academia. And it seems to me that that's how we're going to drive improvement here in the state of Texas. So thank you all for doing that and doing it so well.
Thanks, everybody.
All right, very good. All right, the last item that I see on our agenda, if I'm going to go back up to, or the next item, 3H, we want to hear from HHSC on their work with Zero Suicide Initiative and their suicide preventive activities. Sonia Gaines from the Health and Human Services Commission, and then Tammy Weppelman and Lillian Gwynn. If you're here, I would love to recognize you and hear about the great work that you guys are doing.
Hi, how are you today? My name is Tammy Weppelman. I'm the Suicide Prevention Coordinator for HHSC. I'm going to share a brief slideshow if I can. I'm not so used to Zoom. We use a lot of Teams with HHSC, so I want to make sure I'm doing this right. Y'all can see my screen?
We can see your screen.
All right, great. So I'm going to talk just briefly about the Suicide Care Initiative, which I oversee, and talk to you all a little bit about zero suicide, and then I'll take some questions. Just a brief definition of suicide care for y'all. Suicide care is a systems approach to suicide prevention. Historically, we've talked a lot just about suicide prevention in silos, but now we're looking more at suicide care as all-encompassing of suicide prevention, intervention, treatment, and postvention as one suicide care system. And so it's a continuous and trauma-sensitive approach to the care of individuals needing help with suicide risk. So the Suicide Care Initiative is the initiative that I currently oversee, which is a mental health block grant funded project out of HHSC office. which the focus of which is to enhance suicide care in the public mental health system through the local mental health authorities and the local behavioral health authorities. Zero suicide is specifically a foundational belief that suicide deaths for individuals in the healthcare system and behavioral healthcare system are preventable. And it's a framework which was set up with research and evidence-based practices for system-wide transformation towards suicide-safer care. So the zero suicide specifically is a framework which has tenets, and each of these tenets needs to be implemented fully for an agency to be declared as a suicide-safe care agency. So there are 7 tenets. The first tenet is lead, and this element represents an agency's leadership, which believes that one suicide is too many for an organization. And it also believes in what's known as a just culture. So where deaths by suicide are treated as a systems issue, not an individual failure. So it's not the failure of the individual clinician treating the person, but as a systems issue. And the system is looking for missed opportunities and lessons learned. The train element, or number 2, is training a competent and caring workforce, which is ensuring that everyone in every department of the agency has at least a basic gatekeeper training for suicide prevention, so they know how to ask about suicide and where to refer an individual if needed. The identify tenant is talking about screening for suicide risk at every visit with an evidence-based screening tool, and then referring for a full risk assessment if an individual screens positive. The 4th element is engage, and engage has 2 parts. The first one is engaging the individual in a collaborative safety plan at the same time as their risk assessment, and then also engaging them in suicide-specific treatment at the organization. And then treat kind of goes along with that. Historically, we have treated suicide as a symptom of another mental disorder, such as bipolar disorder or depression. But the treat element says that we will treat suicide as its own condition with evidence-based treatments specific to suicide, such as the collaborative assessment of suicidal behavior, or CBT-SP, or other specific treatments for suicidal behavior. The 6th element is transition, and for transition, we're talking about transitions between care. So as I'm sure all of you are aware, transitions in care are among the highest risk times for people who are experiencing a suicidal crisis. So providing warm handoffs between emergency departments and outpatient clinics, or inpatient psychiatric hospitalizations and outpatient behavioral health can save lives. So really paying attention to those transition and care times. And then improve is exactly what it says, which is providing continuous quality improvement by really looking at metrics and measures for each of the previous tenants, and continuously looking at how many screenings are you doing, how many safety plans are you doing, how are you doing on those care transitions, and always looking to improve. So the way that zero suicide fits into the suicide care initiative that I'm overseeing for the state currently is that zero suicide is the framework of best practices that we are using to implement suicide safer care in the state currently. So zero suicide is basically the mechanism by which the behavioral health organizations are providing suicide safer care in their organizations. So we have each of the 39 local mental health and behavioral health authorities working towards implementing zero suicide in their organizations. So that is what I wanted to share with you today. This is my contact information, but I'm surely available to answer any questions that you may have.
Very good. Thank you. We have some time if there's any questions from the executive committee members.
This is Luann, and one of the reasons we wanted HHSC to come today and talk about this is that several of us were on a call with them. I guess it was probably, I don't know, 6 weeks ago or so, and it was suggested that we present the information that they presented to the executive committee specifically to determine whether or not the framework that's being used could be applied across or within some of the HRIs and some of the work that we're doing with children, youth, and families. And so wanted the folks, and thank you so much, Tammy and Lillian, for coming today. I know Sanjay had to leave early, but we were very excited when we heard about what you were doing and just wanted to let the full consortium hear about it. So thank you.
Very good. Any other comments? Hearing none. Tammy, thank you for being here today, and to the folks at HHSC for your ongoing work and being willing here to share the work that you're doing today. So really appreciate it. Thanks.
You're very welcome. Thank you.
Yep. Okay. With that, Luann, I think we have gone through all the items on the agenda. Is there anything that I'm missing?
Actually, David?
Yep.
We didn't do I had one action item as part of the CPW update.
Okay, good. Okay, yep.
It should take no more than 5 minutes.
No, absolutely. Yeah, thanks for reminding me. Yeah, let's go back up there. Yep.
Yeah, no problem. It's if you could put up the one that says CPW revised metrics, if we could share that with everybody. I believe this will require a vote of the executive, but let me.
Okay.
When we get up there, you'll see what it is.
I'm opening it right now, Dr. Flister.
Sorry, what?
I'm opening it right now.
Okay, great. All right. So actually, if we could scroll down so people can see number 9, scroll up rather, I guess. There. So when the CPW program development documents, which you all have, were first developed, we had voted for 9 metrics, the last of which, number 1, was going to be a measurement of outcome on some symptom measure. Now, the CPW work group and then the CPW operational committee met extensively to see if there's a practical way to do that across multiple LMHAs and non-LMHAs. And in short, there is not, particularly given, COSH's mandate that TRAIT will look at collecting some outcome data within the TCHAT program. It was simply not possible to deploy TRAIT into various LMHAs and whatnot. So the recommendation of the CPW operational committee is that metric number 9 be amended and it become a metric that will measure the satisfaction of residents with the rotation experience, as well as the increase in their knowledge and positive views of community mental health. And it was proposed to measure this in 2 ways. The first being collecting the standard ratings that residents do of the rotations on their various ACGME surveys. And secondly, an internal evaluation team would develop a specific survey regarding community mental health, and that would be administered to all of the residents. And so the CPW operations groups already had some preliminary discussions with Molly, and she's volunteered to develop that. And of course, the committee will then vet that and finalize it, and then it would be issued to all the HRIs to administer. So that's the proposal of the CPW committee. We can have discussion, or we can proceed to vote depending on how people feel.
Okay. So Steve, it sounds like that this is a motion that you have.
Yes, I would move that metric number 9 of the CPW program be amended to be replaced with the text that you see there in yellow.
This is Dr. Potter-Wilson, I agree.
Okay, so I have a motion and a second. Any further discussion?
I think this is a great idea, and it's something it's much simpler than our previous plans, and it really goes right to the spirit of everything.
I think it goes right to what the legislature asked us to do in developing this program. Danette, I see you're on. Any comments from you?
No, I actually had another meeting going on at the same time and was doing my best to stay engaged. And I didn't want to have any concern about a quorum, and wasn't making sure that we were still there. Okay. And also I realized that this is something that we're engaged in directly. So I am here so I can be part of taking the vote.
Perfect, thank you. Any other comments? Hearing none, I'm going to call the vote. We'll do this verbally unless there's disagreement, and then we'll count votes. But everyone that is in favor of this change, as described by Dr. Ptsd, to change the item number 9, as described, signify by saying aye.
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 All opposed, nay. Did anybody abstain? Hear none. I think we have a unanimous vote for the change, Dr. Ptsd. So thank you.
Very good. Thank you.
Very good. So maybe a couple of things before we close. Again, I want to thank everyone for your time. And again, I know how busy you are. And so thank you for your time today. Along those lines, the meeting that we had planned for May, we will not be bringing together the whole Texas Child Mental Health Care Consortium on that day. There may be some additional conversations, and so just as we think through some other items, and so just for the chairs, just want to make sure you're aware that as we're thinking through what we're doing, we may be contacting you, and I don't think, and so our next meeting then would be in June, and at that time we'll have the results from the session. And as soon as, Carol, I promise, as soon as I hear that we get the full funding that we requested, I will be notifying you related to that. Okay. And again, I think we heard some very good news on the legislative front related to the state mental health hospitals and funding, where the funding for the consortium is. And hopefully some additional work related to the other state mental health hospitals that the legislature is planning. Yep.
This is Luann, and I just wanted to say that the next meeting then would be June 18th.
June 18th. Mm-hmm. Okay. All right. Anything else from anybody else before we close this meeting?
Have a great spring.
Yeah, very good. Thanks, everybody.
Thanks, David.
Bye.
Bye.
Bye.